Hello everyone, my name is Hannah Brosnan. I am the Finance and Operations Coordinator with Mental Health America of Kentucky. Thank you for joining us for today's webinar, an overview of clinical high risk and first episode psychosis. This is the third session in a statewide learning series designed to increase workforce capacity to address early serious mental illness and first episode psychosis. This virtual series is made possible by BSCA funds through Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. This is session 3 of 8 in this series. I've linked this series in the chat should you wish to register for additional sessions. I've also shared the series schedule in the chat. Today's webinar is led by Dr. Ryan Melton, PhD, LPC, ACS. Dr. Melton currently serves as Dean of the School of Psychology and Counseling, Director of Assessment, and Associate Professor at Bushnell University. He is owner and operator of Endurance Counseling and Consulting LLC and Clinical Supervisor at Pace Health Hospital. Previously, Dr. Melton has served in a variety of director and university faculty positions. Thank you, Dr. Melton, for joining us. As you all know, this meeting is recorded. The recording will be shared via YouTube. Please make sure you are muted and please put any questions in the chat so that we can get them answered in the end. For today's session, we will start for the first half, and then when Dr. Melton feels it's a good time for a break, about at the halfway point, then we'll take a short break, return for the rest of the material, and then end with a Q&A. So please make sure, again, any questions, just go ahead and put them in the chat. All right, Dr. Melton, pass the mic to you.
All right, thank you. Great to see some of you again, and yeah, we're going to continue on in the series. So today, primary topic is we're going to be talking about FEP, CHRP, and some of the treatment implications related to those stages of psychotic conditions. So FEP, of course, being first episode psychosis, and CHRP being clinical high risk for psychosis. So we'll do some objectives today. We'll make sure that you understand the difference between those two forms or stages of psychosis, and then have some of the specific treatment recommendations for each of those particular stages. This will be building off of the first webinar that I completed, which was kind of a big overview. So there'll be some repetition in that from that, and then we'll plan to go into more detail. But repetition isn't always bad because it's a lot of information. So we'll go from there. As Hannah said, yeah, please put some questions in the chat as we go along. We will take a break roughly about halfway through the session. I might stop at some points to check in on some questions. We'll just kind of see how that goes. And we'll have a huge group today, so happy to answer questions, have some discussion along the way. Okay, we'll continue. My email is there, so do you want to reach out to me? All right, so the first thing that we need to understand, as we talk about first episode psychosis, and really what these programs are trying to capture in first episode psychosis is people with the schizophrenia spectrum and other psychotic disorders. So we're really trying to capture that, the individuals who fall in that chapter of the DSM-5 TR, so the chapter that really covers those psychotic disorders. Majority of first episode programs around the country do kind of focus on schizophrenia. There is some different differentials and criteria around the country in these programs. Some individuals will take individuals that say have like a bipolar disorder with psychotic features, or maybe a major depressive disorder with psychotic features. Some exclude delusional disorders. Some programs take people with intellectual disabilities and psychotic disorders. So there is variation around the country in terms of criteria which programs take for their early psychosis programs. I'm going to speak broadly just and try to focus on the schizophrenia related disorders. Certainly if you have questions about affective psychoses like bipolar disorder with psychosis, like major depression with psychosis, like psychotic-like experiences, drug-induced psychoses, you certainly can ask those. I'm going to go more in detail on those particular conditions and on a future webinar where we do some fine-tuned differential diagnosis and really how you tell the difference between those conditions and schizophrenia. Today, we'll be kind of talking mostly about schizophrenia-related disorders, some characteristics of that particular disorder, as well as the treatment implications for that. Okay, so yeah, starting with kind of your schizophrenia. So the disorders that really count as like first episode psychosis. So when we say that term, we're saying that we have enough criteria, or we have enough evidence to diagnose a schizophrenia related disorder. So whether that's schizophrenia, whether that's schizophreniform disorder, delusional disorder, schizoaffective disorder, some cases of brief psychotic episode, but those are the conditions that I'll be mostly talking about as we talk about first episode. Let's get this out. So schizophrenia, I mean, first thing we want to talk about, what is schizophrenia? When we say this condition, what do we really mean? And what are we really talking about? And a lot of the information that I pull from certainly is the DSM, where this is our tool, this is our manual that helps define these disorders. And I don't believe it's completely arbitrary. I mean, we've been studying this condition for over 100 years, and many of the characteristics have not changed much. So maybe how we recognize it, how we understand it, how we treat it certainly has changed, but the symptoms themselves have been pretty consistent for well over 100 years and are consistent across the world. So even the rates of schizophrenia is pretty consistent across the world. So we have a general idea of what this condition is and what the related conditions are. But I want to make sure that we understand it. So when I say schizophrenia, we're talking about the same thing. So again, schizophrenia, what we're trying to do in these early intervention programs, obviously, is to catch schizophrenia early. That's the goal, right? We want to catch this condition as early as possible, because we believe, and the research supports, that if we catch these conditions early, we can have major impacts on the biopsychosocial cultural consequences, of this condition. We can make lives better or support people's in meeting their goals. We see reductions in hospitalizations. We see reductions in disability applications, and we see reductions in incarcerations and reductions in cost overall. All right, so schizophrenia, when it hits this first episode criteria, it means that there's an active phase psychosis. That's an important term. Active phase psychosis means that the individual's symptoms have reached a point where they've lost insight into what is real and what is not. So that's when we say an active phase, first episode psychosis. Those terms can be used kind of interchangeably. We're really saying that the individual has had an experience with their symptoms that they no longer have insight into what's real and what's not. Doesn't mean that insight can't come back. It certainly can. In many cases, it does come back. But at some point, they've lost insight. And when I say that, I'm saying that they have lost the ability to tell what is real and what is not. And those usually occur in the big three symptoms of schizophrenia, which are delusions, hallucinations, and disorganized speech. Those are your essential features of schizophrenia. Those are the three symptoms where you need at least one of them before you can even make a diagnosis of schizophrenia. So delusions, just briefly, believing things that aren't in touch with reality, believing that the government is tracking you with devices planted in your brain, something along those lines. People can shapeshift, things like that. But it's now reached a level where the individual believes that to be true, that they honestly believe that the government has inserted a device into their brain and is tracking them. And then when you ask them, is it possible that this could be part of your imagination or your brain playing tricks on you, they will say, no, this is real. And they may even become frustrated with you because you're even insinuating that their experience isn't real. Which is one of the major treatment barriers with schizophrenia. So we'll talk about kind of how we work through that barrier, since this is what we're working with here. We are working with first episode psychosis, active phase psychosis, where insight is lost. So we can't come in and be saying things like, this, you don't really have a microchip in your brain that the government has implanted in there. What's really happening is that you have a biochemical imbalance, which is resulting in excess dopamine in certain areas of your prefrontal cortex, which is making you confused about reality. We start saying stuff like that to somebody with a first episode psychosis, they tell us to get the heck out. And we lose potential treatment engagement. But that's what we're working with. That's what schizophrenia is, at least at some point in the condition, that insight is lost. Same is true with hallucinations. Hallucinations is a sensory experience that is believed to be true, by the individual. So that could be in the forms of seeing things not there, hearing things not there, feeling things on your skin, tasting things that aren't there. Those type of sensory experiences. But in terms of the person, they believe it to be real, that feels like a true sensory experience. So how you're experiencing my voice now is exactly or similar to how they would be experiencing an auditory hallucination, hearing something that's not there. It's not an internal thought. It's not a thought in their head. It feels like an outside sensory experience. Then disorganized speech. And that's the type of speech where the speech really just has no end goal. There's no direction to the speech at all. It's not slightly going off topic. It's not being slightly tangential. This is the type of speech that's very loose, very disorganized. You're listening to them and it just does not make any sense. You usually can't even complete an assessment because the speech is so disorganized. Yeah. So that's kind of your third big symptom. But all of those symptoms need to reach a threshold where insight is lost. Then there's a few other symptoms that can also be present but are not required for the diagnosis, and that's disorganized behavior, similar to disorganized speech in that the behavior has no end goal. Doesn't seem to be any purpose for the behavior. So I've had patients that would stack rocks in their room, for really no reason, wear 13 jackets for no reason that they could explain. Those walk in circles and things like that just didn't have a whole lot of explanation. Also catatonic behavior, although catatonia is a diagnosis in its own that can be attached either as a diagnosis in and of itself or be attached to other mental health conditions. For example, you can have major depressive disorder with catatonia. So catatonia is, although present with schizophrenia, also present with a wide range of other conditions and may in fact be a separate condition, something really very much separate from schizophrenia. And then negative symptoms. And so negative symptoms, we're going to talk about these a little bit because they tend to be the symptoms that are not well treated by our primary treatment approaches with schizophrenia, which is medications. Negative symptoms don't tend to respond well to medications and may in fact be caused by medications. So we have kind of a dual issue with negative symptoms. Either they're pre-existing, they existed prior or at the onset of schizophrenia, or they're caused by one of our primary treatments, which is medication. So much so that our diagnostic tools ask us to really determine whether or not the negative symptoms are primary or secondary. Primary negative symptom would be, again, a negative symptom related to the schizophrenia. Secondary would be a negative symptom caused by medications. So negative symptoms, are symptoms that we use the term negative because it means the absence of. So it might be absence of affect, absence of expressive range of emotion, absence of motivation. Those type of things are negative symptoms. We'll go into more detail with those. So you need two total symptoms, but one of those symptoms needs to be either delusions, hallucinations, or disorganized speech at an active level. So all of that has to be in place before we even can diagnose schizophrenia. But that's what the term first episode means. It's when this criteria is met, where you can give a psychotic disorder. So active phase is really the kind of the line in where we differentiate between first episode and CHRP. Once an individual loses insight, we can call it first episode. We can start diagnosing psychotic disorders. Prior to that, we call it clinical high risk for psychosis, and we cannot diagnose primary psychotic disorders. And the reason for that, because there's different treatments, there's different approaches. And again, that is what we'll cover today. For schizophrenia, also you need some significant functional decline or disability, and the symptoms need to persist for 6 months. Now, they don't have to be in an active phase for 6 months, but there needs to be 6 months of symptoms, which can include your prodromal stage, which is akin to clinical high risk, and residual symptoms. Residual symptoms are post first episode where the person regains insight again. So if we look at kind of the phase of schizophrenia, and I'll go over this again, we look at a symptom like, I believe that a microchip has been placed in my brain by the government. That starts off in a prodromal phase of, I wonder if there is a microchip in my brain. I'm starting to feel something. I'm starting to hear things that I think is coming from the microchip, but that's probably my brain playing tricks on me. I don't know what that is. It's bothersome, but it's probably really not a chip in my brain. To active phase, which we can then call first episode. Now the chip in my brain is communicating. It definitely is real. And if you challenge me on it, you are probably part of the conspiracy that helped put the chip in my brain. To then residual phase, which is, I used to believe before treatment that there was a chip in my brain. Now I know that that's not really the case, although it still feels like it's there and it still bothers me. So those are kind of the phases of psychotic conditions using that specific symptom, knowing that you can't diagnose a schizophrenia disorder until they reach that middle phase, that active phase. Schizoaffective disorder is one of those probably more complicated disorders than it is diagnosed. I think it gets overly diagnosed, particularly in children that have been in residential settings who've experienced a whole lot of trauma. I want to be clear that when it comes to a diagnosis like schizoaffective disorder, that it is a schizophrenia, it is a primarily psychotic disorder. So it falls within that spectrum of disorder, meaning that the criterion that I just described for schizophrenia needs to be in place. There's no exception for schizoaffective disorder. Schizoaffective disorder is diagnosed when there's symptoms in addition to the symptoms I just discussed for schizophrenia. And those additional symptoms are major depressive episodes, are manic episodes. And then you still, though, need to it still needs to be a primary psychotic disorder and not a mood disorder, meaning that the person has had 2 weeks where delusions and hallucinations were present without a mood episode. And the symptoms that meet the criteria for the mood episode are present at least half of the time that they've had psychotic symptoms. So if they've had psychotic symptoms for 2 years, about a year or so of where symptoms have been present, they've had symptoms they've had a full mood episode and then have ongoing symptoms of the mood episode. And then you have 2 weeks somewhere in this 2-year period where they didn't have any mood symptoms, but were also either delusional or hallucinating. It's one of those really complicated criteria. So if you watch kind of the trained diagnosticians on really trying to get this criteria, you see them struggle because you have to really pinpoint timelines to even diagnose this. But it is one of those disorders that does get thrown out pretty easily at times. Again, particularly where I see this disorder diagnosed the most, and I'm going to add inappropriately diagnosed the most, is again children and adolescents who have been in residential treatment or traumatized, where they don't actually meet criteria for schizoaffective disorder, but the clinician who diagnosed this was confused or presented in a way that they thought that it was schizoaffective disorder. It wasn't, which again, harmful, because now we're diagnosing usually young people with a misdiagnosis, and then we're providing treatment for them that is inappropriate, not to mention that we're labeling them and saying that they have a psychotic disorder when they don't. So I always kind of tell early psychosis programs, especially new ones that are kind of getting into this work, that be cautious of the referrals that people say have schizoaffective disorder especially when they're adolescents or children, because those are just unlikely to be accurate diagnoses. Anyway, kind of got off on the diagnosis thing. We're going to talk again more details on that in the final webinar. All right, so if we look at some of the symptoms of schizophrenia, about 75% report auditory hallucinations. There are other forms of hallucinations, tactile hallucinations, gustatory hallucinations, olfactory hallucinations, visual hallucinations. Those are all forms of hallucinations. The most common hallucination, though, with schizophrenia is auditory hallucinations. So hearing things that are clearly an auditory sensory experience that the person cannot distinguish between other auditory sensory experiences. So that's kind of your true definition even of an active phase first episode auditory hallucination. So that's important to know. Other forms of hallucinations, schizophrenia shouldn't be your first diagnosis. There may be some other conditions going on. But hearing voices essentially is a primary symptom of schizophrenia, which means for treatment, at least in first episode programs, that we do really need to be thinking about treatment approaches that are addressing either coping skills for hallucinations, or learning to kind of work with the hallucinations if we can't help the individual cope with them. Delusions, about 1 in 5 of people with schizophrenia report delusions. So having that belief that something is, that believe something that is real when in fact that it is not. This is very complicated when we get into first episode treatment, because as I mentioned before, this is when the individual firmly believes that what they're experiencing is real. And so we as clinicians coming in to provide psychoeducation on what mental illness is or what mental health symptoms are can blow up in our face really quickly if the individual truly does not believe or does believe what they're experiencing to be real. And I challenge you to kind of, one example that I'll give to trainees sometimes is, if you have a social media account and you're scrolling through your social media account and you see a family member post something political that is completely 100% opposite of what you believe, rarely do you read that and go, good point. You never do that. You continue to scroll, or you think, wow, my uncle in this other part of this country is really odd and believes odd things, and that's not real at all. And you're almost maybe even offended by it. You have to take that experience and translate it to individuals who are having delusions. You providing even kind education about, hey, it's quite possible that this is a neurochemical imbalance that is changing parts of your brain that are making you believe things that aren't real. That can really blow up in your face really quick. They can dig their heels in, and you lose that ability to engage with individuals. So we have to take a much different approach when we're working with individuals with first episode of psychosis with the presence of delusions. And once delusions get kind of fixed, even the medicines can be tricky in helping them respond to them. So again, we have to take different approaches. So our goal really shouldn't be, we need to reduce the delusion, but maybe something along the lines is more functional based goals. Like, how do I work when I believe that my brain is I have a microchip in my brain? How do I have friends? Who do I tell about this? Who's safe? Using much more kind of coping with almost radical acceptance of the symptom versus trying to reduce the symptom. And that's some people with delusions. Others will have delusions, and then they'll move into a residual phase of schizophrenia, and they'll have insight. They'll be able to say, yeah, I used to believe those things. I don't believe it anymore. But sometimes it does get worse. Then it's a different treatment approach, reality checking, symptom coping, those type of things. So even within first episode, and our treatment methods can be different based on level of insight. I honestly believe that, in the town that I live in, there's a primary mental health agency, and there's an unhoused individual who I perceive to have some type of psychotic disorder, who sleeps kind of right on the corner, right almost in front of this mental health agency, but he's not an active patient there. And the reason why he's not an active patient is because he's got a fixed delusion about some unusual things. And when somebody tries to help him to get him to sign up to get mental health care, he says no, because he doesn't believe that he has a mental health condition. And that's, I think, one of the challenges with mental health in that way, is that we sometimes have people have to sign all these consents and do all these documentation that really has them acknowledge they have a mental health condition. And for many people, many mental health conditions, that's fine. Depression, anxiety, trauma, that's fine. But when someone has schizophrenia, when when about half of individuals with active phase who have had a first episode of schizophrenia don't regain insight, that's problematic now, because we're trying to engage somebody in a treatment that for something they don't believe they have. I mean, how many of us would go to a doctor for a condition that we don't believe we have just because someone told we had it? I mean, maybe not many of us. So that's one of the real challenges with this type of work. And so part of my talk today is like, how do we work around this? How do we engage these individuals that really meet this first episode and then don't regain insight? And it's just to complicate it even more, other symptoms, which we've talked about, these negative symptoms, which many people report are more disabling than the voices or other psychotic symptoms. Clients that I've spoken to will oftentimes more complain about, who have insight even, will even more oftentimes complain about negative symptoms than they will about the positive symptoms of hallucinations or delusions. And then something that's not listed in the DSM, but really important for treatment, which we understand to be true about individuals with schizophrenia, is that there is a series of cognitive and behavioral changes that have occurred. And some of the cognitive changes don't come back at the same rate as we see with improvement of positive symptoms like hallucinations and delusions. So on average, that once a person reaches that first episode of psychosis, there is on average a 10-point IQ loss. So that means cognitively, some of the cognitive abilities that the person had are not present following when they meet that criteria for schizophrenia, when they've had that true first episode. So there is some cognitive changes. And then many of us aren't trained in assessments that can pick up on those, or we don't even think about it. The DSM, may write about it in the text portion of the chapter on psychotic illnesses, but it's not a criteria. But we do also know that it's present in a good portion of individuals, that there is some cognitive loss, and that they don't always fully come back, even in the residual phase when things start to get better. So something we have to, again, also has a lot of implications for treatment. So again, to be clear, let's kind of go through some of the symptoms. Again, for hallucinations, talked about this, there are visual, auditory, tactile, gustatory, somatic, and olfactory forms of hallucinations. And the true definition is a sensory perception in the absence of an actual external stimulus. So hearing a voice where there is not an actual voice being said. And these occur within all of our sensory systems: sight, hearing, taste, smell, touch. Again, of course, when fully conscious, we know that when we dream, we actually kind of hallucinate, or we get confused on what's real and what's not, sometimes when we're just falling asleep or just waking up. So that's not what we're talking about here, of course. And the internal stimuli, whatever it is in any of these sensory systems, feels real. It's not, I'm not sure if if I'm hearing a voice or if it's my own thoughts. If a client's saying that, that's probably not a hallucination. They need to be saying, at least for the first episode, yes, what I'm experiencing is real, or it feels as real as your voice to me, and it feels like it's coming from outside of me. It's kind of the key term, that it feels like it's coming from the outside, that it's not an internal process. And that's one of our distinctions between, say, a hallucination and a disturbing internalized thought. Again, most common with schizophrenia is auditory, although it's not unusual that clients may talk about tactile hallucinations, for example, feeling something on their skin, particularly if they have a delusion that maybe they believe that there's been something implanted in their skin. They will sometimes say, I feel it in my body. So oftentimes the other form of hallucinations outside of auditory are related to delusions. So olfactory, for example, they might talk about smelling. I got a client that believed they had murdered somebody. They had not. And they would sometimes talk about smelling their body, smelling the dead body and things like that. So I think it was very much related to the delusion. So important for us to kind of pull that out. We don't want to just be saying client has a presence of hallucinations and kind of go with that. In this type of work, particularly with first episode psychosis, we really want to get down to exactly what they're experiencing to the extent that we can, because that's going to really kind of inform at least kind of therapeutic forms of treatment. Delusions, wide range of delusions that individuals, mess with this a little bit, sorry, here we go. Wide range of delusions that individuals can experience. And for me, it isn't enough to say that the client just experiences delusions. I really want to know the type of delusion, because once we start getting into treatment, the type of delusion really can matter. I'll talk a little more about that. Let's just go through a couple of these. You can read these. You may be familiar with them. I don't always know my level of experience on my training, so I try to might be talking about some things that you are very much familiar with, and I apologize for that. So hopefully I am getting you a little bit more detail. We generally separate out delusions by kind of two big categories. And those first two categories are bizarre versus non-bizarre delusions. The differentiation between a bizarre delusion and a non-bizarre delusion is that a bizarre delusion involves a situation that could not occur in everyday life. So like being transported off this planet by aliens. That's not to say that aliens don't exist. I know a good portion of the population believes that they do, but being transported, we don't have good evidence that that has occurred. Or maybe even the example I gave earlier, that the government has snuck in somehow and inserted a microchip into your brain while you were sleeping. That would be an example of a bizarre delusion. Non-bizarre delusions are delusions that could involve situations that could occur, like being having a disease you don't really have, being followed or being loved by a celebrity, or that you have a relation that, or that a celebrity is in love with you, that when in fact they're not. So those are non-bizarre delusions. What we see in schizophrenia is things that tend to be closer to bizarre delusions, that tend to be leaning more towards things that just could not occur, or that would be really, really, really hard to occur in everyday life. Versus non-bizarre delusions do tend to occur in other forms of disorders. Certainly do see it in schizophrenia as well. Most commonly, we see non-bizarre delusions in delusional disorder, although bizarre delusions can also occur with that disorder as well. But with non-bizarre delusions, we can kind of ask, well, I guess in both cases of delusion, we can kind of ask about the individual's experience. And that's one technique that I recommend. We call it collaborative empiricism, where we're not necessarily challenging the delusions, but we're asking about the experience of the delusions. Again, without a collusion. So we're not in any way saying that the delusions are real, that we agree with them. That's not what I'm saying. But what I am saying is we can't ask about the person's experience and how they came to believe these things. That in and of itself can be therapeutic. That sometimes induce a little bit of doubt, but at the very least can give us as clinicians ideas on where to go with treatment. So again, I had worked with an individual that did believe that he was tracked by the government, and he would do some unusual things like put sticks up in his front yard as they somehow would block the government from tracking him. It was difficult for him to leave his house because he was going to be tracked. Difficult, of course, then difficult to hold down a job, those type of things. And part of the work that we did was not me challenging him that the government wasn't in some ways tracking him. But I would ask things like, well, I know you went to the store the other. How did you get out the store? Tell me about that. What did you do? He's like, oh, well, I moved some sticks a little bit. I was quick. And I, got this, and I was in the car, and cars tend to be a little bit more safe. He's making some statements like that. And from that, I could start to build off of, how'd you do that? What did you use to really protect yourself? And then we ultimately got him working. But he had to do a few strategies in the morning, move some sticks around, those type of things. Actually, he kept some sticks in his pocket but that allowed him to go to work. Lost a few jobs, unfortunately, but he lost them because he would talk about these things a lot. So once we got the work, the next phase of our treatment was kind of who you talk to about this and who you don't. You and I can talk about it, but maybe you don't talk about it at work. And I normalize that. Like, there's things that I can't talk about at work. And there's things I talk with my friends about and all that. So and he never got to a point where he believed that the government wasn't tracking him. He always believed that throughout treatment. And he took medicines. He took antipsychotic medicines. He didn't take them for the delusions. He took them for other reasons, at least in his mind. And they never really got to that. But I never once challenged him on it, is these things being real or not real, really just kind of focusing on the experience and really finding things that we could agree on, which how scary and terrifying it would be that you're being followed by the government. That would be terrible, and so much so that it makes it hard for you to work. And so I could do some basic empathy there around his experience, which was accurate. That was very real. And we both could agree that experience would be absolutely terrifying. There's other forms of delusions of control, that forces are controlling your thoughts, delusions of guilt, that you're responsible for a tragedy or disaster. Work with a client that believe they caused the attacks on the Twin Towers, delusions of grandiosity, of special powers, delusion of jealousy, that your romantic partner is being unfaithful, or automatic delusions that there's another person in love with them that isn't. So there's all those persecutory delusions, that you're being conspired against, cheated on, spied on, poisoned. Somatic, that there's something involving your body, that you have an odor or that you have a parasite when you don't. Delusion of reference, that some things that are ordinary or insignificant actually have a relation or a special meaning for you. Worked with an individual whose first name started with B, and when he'd see license plates with B on them, he believed that those were individuals that were following him, and that was evidence that he was being followed. Delusions of replacement, that someone's been replaced by a double. Nihilistic, that maybe you don't exist. And then the three, what we call first rank delusions, particularly with schizophrenia: thought broadcasting, believe that your thoughts are being broadcasted so much so they can be heard by others. Thought insertion, that thoughts are not your own, being placed into your brain. And then thought withdrawal, that somebody's actually stealing your thoughts. Certainly important for me to understand what's the delusion itself, and maybe even where it comes from, because then that's where I'm going to target my treatment. It's some of the cognitive behavioral therapy with psychosis work will look specifically at delusions, and then we'll hold that delusions have meaning in one's life, maybe even going back as early as childhood. So like a delusion of grandiosity, for example, may in fact be that the client really wants to feel really important. So instead of challenging a grandiose delusion of saying, well, that's not real, you're really not the president of the United States, maybe saying something like, sounds like that would be it's a really important job. Sounds like you would really like to take responsibility for people, as you're kind of working through, as you're kind of doing kind of the therapy with individuals that have those type of delusions. Because then you can start saying, yeah, I do want to be important. I do want to be powerful. Where do you think that came? Where did that belief come from? Tell me more about that. So again, always just kind of asking questions about the experience, not necessarily challenging the experience in this kind of first episode world. But you can't really ask those questions until you understand the theme of the delusion and what the delusion is. And I understand that you are going to be having some CBT training, and you'll probably hear more about how using themes of delusions in treatment can be really important. All right, moving on to another symptom that we know is present in schizophrenia is these negative symptoms. Again, so negative is the removal of or the absence of something that was there at one point. So affect flattening. So our affect, if you're not familiar, is the outward expression of one's mood. So we can generally tell what people's moods are kind of based on how they're what's looking on their face. With some symptoms of schizophrenia, the affect is just flat, where there is no expressed emotion at all. And even when the person is happy, we don't see smiling. We don't see an outward expression of that internal experience. Poverty of speech is just not talking a lot. It's not the clients that say, I don't know, I don't know, I don't know to every question you ask them. These are the clients that maybe just give you one word responses. The inability to experience enjoyment, maybe this, they lose this ability to really enjoy things that they normally did not enjoy, or normally did enjoy, sorry. Lose interest in relating to people, lose initiative, and have some inattentiveness, are all just some examples. There's others, but some examples of negative symptoms. Now, for a treatment aspect, particularly in first episode psychosis, first and foremost, we need to understand where these negative symptoms are coming from. Are they part of the condition? So we need to understand, did they exist prior to treatment with antipsychotic medications? If they did, we call those primary negative symptoms. Those are part of the condition. If the negative symptoms started after the onset of antipsychotic symptoms, we at least have the suspicion, it may be a progression of the illness, but we at least have the suspicion that these could be secondary negative symptoms. If there's secondary negative symptoms, then one of the treatment could be working with the prescriber to find a medicine with a lower side effect profile. I know that could be a challenge in and of itself, but to reduce the impact of the negative symptoms as a side effect of the medication. If they are primary negative symptoms, then we're doing, treatment that really addresses negative symptoms. Peer support specialists, case managers, people with skills trainers. A lot of clients, when they have these negative symptoms, will lack initiative. But it doesn't mean they don't always want to do things. It's they don't know how to do things, or they've lost that ability, or they lost that initiative to start things. So having a skills trainer, having a peer support or case manager, being able to go do something in the community with somebody, and to get them over that hump, so to speak, can be a really valuable intervention. It doesn't work well to be sitting in your office with somebody with schizophrenia who has negative symptoms and say, wait, let's make a couple of plans of things you're going to do this week. You're going to get out of the house 3 times. They might say, yeah, I'll get out of the house 3 times. That sounds like a good plan. But then they don't. And again, their don't is not in most cases, I don't believe is an unwillingness, but I think is more of an inability to, or that there's so many barriers because of the negative symptoms or potentially cognitive symptoms that is keeping them from doing those goals. Not like they didn't want to get out of the house. This isn't a compliance issue. I don't think. I think it's more of an inability issue. So instead of saying, try to get out of the house 3 times, it's, what do you think would be the barriers to getting out of the house? Could I send a case manager, a skills trainer, or peer support over to help you get out of the house? And kind of doing, and then asking with experiences as they're out of the house. So really that more in vivo type of work works so much better with individuals with negative symptoms. So really almost doing with, as opposed to giving them plans to do something. So really important treatment feature. And then cognitive impairments. So kind of something that I refer to as kind of the invisible symptoms within an overall invisible illness. So these are impairments around thinking. So cognition has to do with thinking, that we note tend to be present in the clinical high risk phase of psychosis. So as people are developing a psychotic disorder, cognitive symptoms are already starting to be, we believe they're already starting to be present, and they tend to predate the onset of positive symptoms. And then once first episode hits, they continue to decline until treatment occurs. So these symptoms, so some of the common ones, like challenges in working memory. So if we think about what working memory is in a simplistic way, working memory is really part of our memory system that takes information. So even information that you're hearing from me right now, and then it goes into your short-term memory. And then whether or not it's salient to you, or you practice it, or you rehearse it, it tends to slip from your working memory and is lost. If you continue, if what I say to you actually has importance, you're like, oh yeah, actually, I was thinking about a client like that. You may remember it more, and it gets stored in more long-term memory. It's a very simplistic way of how memory works. But I like that example because then it kind of tells us with people with schizophrenia, if their working memory is impaired, it means that almost a good portion of what you're telling them or what you're trying to provide education on slips away. So this is important with treatment, that we have to, in a lot of ways, move away from the traditional talk therapies and really use more activity-based therapies, use doing a lot of worksheets. So using illness management recovery is one example, individual resilience training, some of these CBT, cognitive behavioral therapy for psychosis, these models all have components that are very structured, they're repetitious, you write things down, you give handouts, you can record things if you're doing it over Zoom. It adds a different element to compensate for working memory deficits. Telling somebody, okay, you should get out and walk 3 times this week may not go very far, and primarily they may have lost it 30 seconds after you asked them to do it, even though they just told you they would do it. So we just have to be aware that these symptoms are present in a good portion, and of course they vary across individuals, but I like to at least be thinking about, if this person truly has schizophrenia, that there probably is some cognitive loss here, and I need to compensate for that. Verbal processing. So processing information verbally is impaired. So that does put a limit on our ability to do just primary talk therapy. We do want to add activities. I think I always say that one of the biggest helps for therapists that work with this population is a whiteboard. If they're seeing people in office, or using the whiteboard feature on Zoom or Teams or whatever video conferencing program you use, to be writing things down, saving things. Cell phones have made a world of difference, taking pictures of things, recording things, using the notes features, using the symptom trackers. People have their phones with them quite a bit. So we can kind of use that to our advantage to help, again, as an adjunct to some of the cognitive impairments that have happened. Executive functioning is really our kind of judgment and decision-making part of our brain. What our brains like to do, I'm going to simplify it, but when we're presented with complex information, we tend to like to make it simple. We like to think of things in a whole. And I think there's probably roots in why some of us are racist and all those type of things with this type of neurocognitive skill that we have. So I'll give you an example, even something like taking out the garbage. If in your household, someone asks you to take out the garbage, or you think, oh, I need to take the garbage out, we can take the 100 steps that actually go into taking out the garbage, and we'll change it into a couple of steps in our brain. Our brain will just do that automatically. Okay, take out the garbage. Yeah, just grab the garbage out of the can and throw it in the outside garbage, take it down to the corner. 3 steps, right? Well, it's actually not 3 steps. It could be upwards of 100 steps. Well, I got to find the bag, pull out the bag, open the bag, take out the old bag, put in the new bag. Maybe I wipe the trash can down. Maybe I don't. Walk all the steps to the garage, put it in that garbage can, then pull that garbage can down. All of these steps that we consolidate into single steps is really what our executive functioning part of our brain does. It consolidates things. Individuals with schizophrenia sometimes lose that ability to consolidate information, so steps are lost along the way. So this is why sometimes we'll see clients maybe asked to do something, they'll kind of stop, like, what was I doing? What's the next step? Even it could be really simple type of things. They lose that ability. So this is important when working with families, is when they have a family member with a first episode psychosis, that when they're saying, well, they're just not motivated and they refuse to take the garbage out, or they refuse to clean their room, or they refuse to do this, they won't do that. I like to reframe that in a lot of ways, saying, I wonder if it's part of the condition, that they're now struggling with some of the things that used to be pretty easy. And because they've just had this first episode, these things are a little bit harder. We hope that they'll come back. And I think in a lot of cases, they do come back with treatment. But right now, we might need to lower our expectations, for the individual as they're recovering through this, even something as simple as taking out the garbage. Now, that's not me saying don't have them do any chores or don't do anything around the house. Just we might just have to have a little more patience with it. We might have to do some more step-by-step instructions on things that are seemingly pretty simple. Those type of things. Sensory deficits. We know from some of I was involved in the EDIP trial, which was kind of looking at people who were potentially developing schizophrenia. And what we found in that trial, we did sensory profiles with everybody. So we're looking at their sensory integration. And we learned that a good portion of individuals who are at risk of schizophrenia were sensory avoiders with low registration, which meant that if certain sensory information was too pronounced, they would shut down or struggle. And they needed a certain amount of sensory input to be activated to even take in information. So it almost kind of taught us that we have to find this optimal level of sensory input before we can engage in treatment. So what did that look like? I mean, it certainly varied from individuals, but so what do I do? And what's in my office when I was seeing patients? A bunch of tactile things, your fidget spinners, your little squeeze balls, your other type of tactile things. Watch your clients. They will pick those up and they will play with those. They will mess with those and they'll talk more. It's kind of this, we have to almost turn on the sensory system before they can kind of engage, even a little music in the background. The challenge is we can't go too far. Can't have music blasting, sometimes can't have too many lights on. There can also be this sensory overload that can occur. So it is trying to find that optimal balance of sensory input to get the best outcome. So what are we telling families? Maybe if you keep all the lights on the house, maybe don't do that. Maybe have a few lights on. Maybe don't have so much media happening all at once. Maybe when you talk to individuals that you're keeping is the best of your ability. I struggle with it sometimes with my own children, but staying calm and talking very concretely when you give instructions, doing step by step, those type of approaches. And then finally, another area that we see a deficit with schizophrenia is social cognition. And social cognition is that ability for us to kind of recognize social cues, for lack of a better word, which means sometimes people with schizophrenia also, they have the effect of that they're losing some outward, they're losing kind of from negative symptoms, having affective challenges, affective flattening, and they're losing the ability to understand other people's affect, what other people are mean, what other people are saying, starting to pick up or losing the ability to pick up on sarcasm, things that aren't as concrete. So really kind of thinking about that too. And that's both for psychoeducation with family members and support systems, as well as our own work, with clients, trying to be as concrete and planful as possible when we're doing therapy with this particular population. So I hope you've kind of seen now is why I wanted to spend some time really talking about schizophrenia in more detail with this first episode population, is because not only are they experiencing potentially voices and delusions, which has its own form of treatment, but they're also needing to work through negative symptoms and cognitive impairments. So this is a complicated disorder that we're really, really trying to work through and treat. And we have to take it kind of all into account without, in some ways, blaming the individual, which is hard. I think it can be hard when they're not just really thinking past that they won't do this to they might not be able to do this at this point due to some of these symptoms that I just described. In terms of the onsets and everything else, schizophrenia, this is a condition of late adolescence and early adulthood. This is not a condition of early childhood. Rarely does schizophrenia occur in childhood. It sometimes gets diagnosed in childhood. So I'm talking pre-puberty here. It's not a childhood disorder. Most diagnoses of individuals under the age of 12 with schizophrenia don't have schizophrenia. There's probably something else going on there. So it is not. Even if you look at the DSM definition of early onset schizophrenia, I think that term confuses people. They're really just kind of talking about prior to 18, so it's not prior to, 13 or something like that. So generally CHRP symptoms start to develop, in your mid to late teens, with your first episode of schizophrenia happening in your early to mid 20s. It's kind of your age range. 85%, I might be off slightly on my stats here, cases occur between the ages of 15 and 25. So the majority, again, so this is again, late adolescent, early adult disorder, which from a treatment standpoint, talk about a really complicated time in life, where you're not only kind of trying to understand your own identity and where you want to go in life. Am I going to go to college? Am I going to go to work? Am I going to start a family? All of those kind of cultural and societal pressures that come with being an adolescent. And now you're starting to develop this really confusing neurocognitive disorder, which is causing you sensory challenges, cognitive challenges, as well as maybe you're starting to believe things that may not be real, which can really, really shift identity. So a lot of our work in early episode or early psychosis programs is to really try to focus on identity development, really keep people on their kind of developmental life choices in their past. If they're in school, keeping them in school. If they want to go to college, trying to support them in going to college. My talk yesterday was all about support employment and education and how valuable that is in early psychosis programs, because those are the interventions that are most salient to these individuals. I want my identity to be someone who's going to college, going to work, being a parent, not an identity of someone with schizophrenia. So again, we have this complicated disorder, this condition that's happening right as people are making really big identity decisions. This is not a condition of individuals who are in the low socioeconomic status. Certainly people in lower SES, there's more stressors, and stressors we do believe can induce this condition sooner rather than later. However, this is a condition that's, the amount of money that one makes does not seem to impact onset. In our programs in Oregon, we have individuals who are unhoused who have this condition for first episode, and we have millionaires, children that are in our programs. This is not a condition of social economic status, although we do recognize there's that downward drift, right, of people who develop this condition, who go on disability, who move towards poverty, but it's not necessarily causal in that way. We do believe that this is a condition of stress vulnerability, meaning that we do believe that there is some biological genetic component to it. This isn't primarily a social or psychological condition. It's a combination of things. It falls within that biopsychosocial, cultural kind of combination of causal effects. But there probably is something there. There may be something there as maybe that was even present at birth or prenatally that does not really get turned on until late adolescence, early adulthood, certainly influenced by stress. So the more vulnerable the person is, the more likely that the condition starts. And we do know that the higher stress levels that the individuals have, the worse outcomes, particularly in first episode psychosis. So higher levels of stress can mean worse prognosis. And when I talk about stress, I'm talking very broadly about stress. And it's really about how the person perceives stress. I mean, what one person might find stressful, another person doesn't. So it really will be about how that individual perceives stress. But a lot of the stress that we work on in these programs are stress with the family or the primary care providers. It's kind of even how to talk to the individuals. Talk more about that later in this talk. To illicit substances, the stressors that the person is putting in their body or on their body. We do know that marijuana in particular is very dangerous for individuals, both in the CHRP stage of this condition, as well as first episode. And we do also recognize that we are not very good prognosticators when it comes to this condition, that somebody can look really sick, be hospitalized, be committed, after their first episode, and then 6 months later be doing great. And then other people with mild symptoms, 6 months later be doing terrible. This is it's a slow kind of insidious course with a wide variability in prognosis. So we don't want to put prognostic factors on individuals. And because one, we want to keep them to be hopeful, and then as well as their families. Families can be, of course, can be traumatized by this, seeing their family member hospitalized, maybe involuntarily, maybe against their will, with really significant symptoms, accusing them of stealing money or poisoning them, which they didn't do, and then trying to be able to educate families that we don't know where this is going to end up, that with these severe symptoms that they're experiencing right now is not necessarily a future predictor of what the symptoms are going to look like in a year from now. And time might be on your side here as long as we move through a recovery process. So kind of giving hope in that way, but it can be, of course, really scary. And then kind of working with families around this issue. Works the other way though too. I mean, I also experienced families where the client was hospitalized, did really well in medicines and treatment within 3 months, looking great, and then the family is then like, okay, everything was fine. This was no big deal. Let's get back to work full time and back to school full time. And then that stressors of that was too much. So we have to kind of balance that some clients that look great, we still need treatment, because there is that natural inclination to pull people from treatment, which makes sense, right? We have generally a medical model in this country is that you go see a doctor while you have symptoms, and once your symptoms are gone, you're good. Whereas schizophrenia, even though the symptoms are gone or minimized, the condition is still there and can reemerge under the ideas of stress. So we just have to be cautious and monitor and make sure families are aware of that. Okay. So I did kind of talk about that this is a kind of insidious progressive condition. So what we do believe is that individuals, when it comes to schizophrenia, that it probably was present at birth or even prenatally, whether that's some type of viral infection, some environmental toxin, genetic disease, maybe a brain abnormality. Either way, those things kind of create vulnerability towards the condition. However, the condition doesn't seem to strike or come on until post-puberty, but the vulnerability is there. And maybe early on, there are some subtle features of the condition that we don't really have good tools to pick up on, but they're there. So you already heard me say that one of the earliest features of schizophrenia is not voices, it's not hallucinations. That's just what we use to diagnose it, but that's not what the early symptoms are. What the early symptoms are cognitive deficits. Are again this inability, some of those cognitive deficits that I brought up earlier, challenges with working memory, executive functioning, social cognition, that are present before the onset of the primary psychotic symptoms. So what this looks like is an adolescent now is starting to struggle in school for no known reason, nothing that we can pick up on. They're describing that the work is harder, they can't think, they can't focus. When you do retrospective interviews with family members, it's not unusual that a family member would tell me that, when they were about 15, we thought they had ADHD. We got them treated for ADHD. In fact, it may have been ADHD, but it also may have been early schizophrenia symptoms, at least some of the cognitive deficits related to that. From there, it progresses to affective symptoms, primarily depression, or what looks like depression. Some argue this might be early negative symptoms. It could be. There's some studies that suggest that in males, this might be the case. It doesn't seem to be as prevalent in females. And from there, social isolation starts to occur. And then this is when now we have a full kind of behavioral phenotype of this underlying biological or genetic condition. And now the individual is really going to start experiencing social and environmental triggers. So meaning that family support systems, school systems, work systems are kind of saying, hey, what's going on here? Why aren't you showing up for school? Why aren't you hanging out with your friends? Why aren't you doing this? So which kind of increases stress Now, this is not me blaming our social systems, or, I mean, as a parent, if my child as an adolescent was starting to isolate in the room, I'd be like, hey, what's going on? What's going on with you? Are you using drugs? I might be doing all of these things. If there's anything to blame here, it's the condition. It's not the family, and it's not the individual. It's we don't understand what's going on. So there's these stressors that are now coming down. And then as these stressors come down, this is when we then start to see this increasing positive symptoms being your hallucinations, your delusions, your disorganized speech and behavior. So those start to develop, then ultimately school failure, and then without treatment, the individual moves towards disability. And what we're trying to do in early psychosis work is really try to catch people as these positive symptoms are increasing, because we do have tools, and we'll talk about those tools later on, to catch individuals who are developing these positive symptoms. Or if we can't catch them there, then we catch them before full-blown psychosis occurs, or right as full-blown psychosis occurs, with really the goal to prevent disability. So in early psychosis work, ideally, if we can catch people while these positive symptoms are increasing here, is that arrow that's kind of moving up towards psychosis, we catch them there, we get some really, really good outcomes. We also get good outcomes if we can catch people very early on, even after they've had a first episode. But I always want to give you kind of the pattern of how schizophrenia develops, but also some of those symptoms that have been present probably for years that we sometimes don't pay close attention to because we're overly focused on the positive symptoms of psychosis, of the hallucinations and delusion. But please remember, negative symptoms could have been present, and in most cases, cognitive symptoms are already present. And again, the longer they go into full psychosis, those cognitive symptoms tend to get worse. So kind of summary, here, 3 phases. Again, I said this earlier, I want to say it again because I think it's really important, because this is really the crux of this particular talk as we talk about early intervention programs. And that there are 3 primary phases of schizophrenia. You see 4, there's one at the end that I don't have here. One is premorbid phase. This could be early childhood, maybe prior to puberty, prior to 10. We don't have tools to kind of really catch it here, but there might be something lingering. Now, this isn't me saying, hey, go out and try to identify 10-year-olds who are developing schizophrenia. You can't, and I definitely don't want you to do that. But just recognizing that there may be something early on in childhood that's lingering. The at-risk phase tends to starts in late adolescence, moving towards early adulthood. And what's happening in this at-risk phase, or we call the clinical high risk for psychosis phase, we start to see a decrease in functioning. So if they're in school, schoolwork is declining. If they're working, their work is declining. If they're a parent, their parenting is declining. Their primary occupational function is declining. And they're starting to develop mild but not fully psychotic symptoms. So they're developing clinical high risk for psychosis symptoms, where the individual still has insight, into what's happening to them. So they might be saying, yeah, it feels like people are really reading my mind, and it's really bothering me, and I can't shake that thought. It's captivating. I need to move to different parts of the room. I need to stay away from certain people because I'm worried they're reading my mind. I know that sounds crazy, but that is really what I'm feeling. Those are all beginning of mild but not fully psychotic, because insight's still intact. Certainly in these programs, we want to capture people there. We feel we get the best outcomes if we can capture people in this clinical high-risk phase. The risk in that is that not everybody who's in this at-risk phase goes on to active psychosis. So there's a balance there. And then ultimately functioning starts to decline, and as functioning is declined, positive symptom psychosis are worsening, and they move to what again we call the active phase of psychosis. And that it's not until this active phase that you could diagnose something like schizophrenia, schizoaffective disorder, delusional disorder, schizophreniform disorder. You wouldn't diagnose those until they reach that active phase of psychosis. But at this phase, again, functioning has really started to decline, and treatment intervention actually becomes at risk at this phase, because of the lack of insight. Our kind of the thing that we really want to reduce when it comes to early intervention work is something called duration of untreated psychosis, or DUP, if you want to give it an acronym. Duration of untreated psychosis is that period of time in which the person develops an active phase psychosis, so the insight is lost, to the point where they get treatment. So DUP kind of measures that time period from the time they reach active phase psychosis to when they get first appropriate treatment. Sorry, I mean, not necessarily treatment in general. The longer this DUP goes, the worse the outcomes. This has been shown in study after study after study after study, and with multiple variables. Different studies will certainly have different outcome variables, but whether that's going on disability, hospitalization, cost to systems, again, I can't find many studies that show duration of DUP means nothing. It means something. And so the longer that it goes, worse the outcomes. Families are broken up. People become unhoused because they're kicked out of the house because they don't have insight. Families are saying, go see a doctor. You're developing an illness. They're saying, no, you're poisoning me. They're like, fine, I can't deal with you anymore. Get out. I do believe there's a wide range of our unhoused population that are just blatantly psychotic, that there's family out there. I mean, I got a coworker that talked about her sister, that she said, I have no idea where my sister is. She developed schizophrenia right around 19 years old. My parents threw her out because she believed that they were stealing millions of dollars from her. And we never saw her again. And that's, so again, I do believe that there's a group of unhoused individuals out there like this that are psychotic. And unfortunately, one of the predictors of DUP is enrollment in a mental health system, which in some ways sounds contradictory, right? Getting help means you might have a longer DUP. And the reason that the authors of this particular study believe that is because when people enroll in a mental health systems are going to do a bunch of things like, hey, you got to sign this consent for your treatment of your schizophrenia. Person says, I don't have schizophrenia. I'm not signing that, even though the clinician says, well, yes, you do. And so then we say, well, they're choosing not to be part of treatment. Well, we can't force them to be in treatment. They're not dangerous, so they don't get treatment. You hit that stage, then the longer that the individual goes without treatment. And the RAISE study found that this DUP is around 72 weeks. Again, I might be off a little bit on that number. That's a long time to be psychotic without treatment. And we found in some of our organ trials that we probably get really good outcomes if we catch people with durations less than 6 months. I published a study years ago that was a qualitative study which I was asking family members and individuals who could tell me about it anyway, when the active phase occurred and how long it took them to get treatment and what were some of the barriers to treatment, things like that. And we definitely found that in the shorter the DUP, 3 months was great. I mean, people that we were caught within 3 months of the first episode did really, really well. Within 6 months also did pretty well. After 6 months, a good portion had already applied for social or supplemental security income and disability payments and those type of things. So we do want to shorten that DUP if we can't just prevent it or catch people in the at-risk phase. That's even better. But if we do hit people with the first in that active phase, we want to reduce the DUP, and we want to be creative in our engagement, because it's such a vulnerable time once that person hits that active phase for them to engage in treatment. I mean, these are the individuals that get hospitalized at psychiatric hospitals, get referred to mental health care, and then they don't show up because they don't believe that they have a condition. All right, go through each of these phases just so you're aware of what they are. The premorbid psychosis, this first phase, about 10 and under, that ESA is a criteria for a program in Oregon. Ignore that. Forgot to remove it for this presentation. There's no formal diagnostic tool to recognize psychosis in this phase. We don't have anything. There isn't brain scans, there isn't blood work or anything like that. We can introduce this. Certainly, I guess if you do have a family member or first degree relative that has schizophrenia, it might be worth monitoring, especially if the individual is having some unusual, maybe movement or cognitive challenges. Worth monitoring. I'm definitely not advocating for treatment, but monitoring. If there is that genetic risk, a first degree relative with schizophrenia, 10, 11-year-olds acting a little odd, struggling in schools, isolating more, and they don't have something that explains it, like depression or autism or something like that. Worth monitoring, but not treatment. There are some studies that have looked at these kids that have found, coordination challenges early. And again, these studies are tricky because they're all retrospective, right? So one of the coordination studies was looking at old VHS tapes of people who had been diagnosed with schizophrenia and then going back and reviewing VHS tapes of when they were in their childhood. And a handful of them had some interesting coordination issues. So they wondered if that was a predictor. A Harvard study kind of showed, when they were tracking people over time with genetic risks, showed that children, adolescents were having olfactory challenges, meaning they had inability to pick up on common smells like oil and certain flowers and things that would be commonly recognized. There tended to be a deficit in that group that went on to develop schizophrenia. And then certainly sensory issues, sensory avoiders, low registration, some of that could be predictors, but definitely not anything at this point that the individuals who are studying, trying to recognize schizophrenia even earlier than the CHRP, are hanging their hat on saying, yep, this is it. This is almost FYI in some ways. Just kind of paying attention to young kids that have genetic risks, who have some changes in the biological, cognitive, or social areas. But I'm definitely not saying rush them to the psychiatrist to get them on antipsychotic medications or anything. This might be more monitoring. The phases that are really important in this talk are now these kind of at-risk phase of schizophrenia. So I'm going to kind of work my way through that, then we'll move on to the active phase. So at-risk phase, again, that's the phase where functioning is starting to decline and they're experiencing low or mild psychotic symptoms, but not fully active psychotic symptoms. Again, most researchers believe we catch it here, we change the trajectory of schizophrenia altogether. And we catch it in this phase. But there's challenges with catching it in this phase. It's easier said than done, for sure. This particular at-risk phase there's a couple of qualities to it that are important. One being that this is usually a help-seeking phase versus a case-finding. This is a help-seeking population versus a case-finding population. So what does that mean? A help-seeking population is exactly what it means, is that this population is coming to you. They're looking for help. So when the person's in this at-risk phase, they do recognize that something is happening, that they have insight into it, and it is disturbing and it is causing difficulties. So they may be seeking help themselves, or a parent or other caring person in their lives is recognizing that something is going on. They may have even disclosed that something is happening to them, which is resulting in help being sought. Once you hit first episode, those individuals aren't coming in usually voluntarily for treatment. They're coming in because someone's dragging them in, they've been civilly committed, or they've been hospitalized and referred to you. That's now you have to kind of go to them once the first episode happens. So we can definitely see the benefit of individuals that are help seeking versus us trying to engage on a more case finding type of process. When we talk about this clinical high risk or at risk phase of psychosis, there's a ton of terms. We've been studying this for a while now. And so, you're going to see if you read the literature, you might hear people talk about this, and they may use different terms. They all mean the same thing. So like ultra high risk for psychosis, clinical high risk for psychosis, prodromal psychosis, attenuated psychosis syndrome, or psychosis risk syndromes. You're going to hear all of these terms. Generally, they mean the same thing. I generally use clinical high risk for psychosis because that's kind of the most current nomenclature for it, or I'll use the term attenuated psychosis syndrome because that's how the DSM-5-TR defines this condition. And there is a diagnostic code that you can use for describing attenuated psychosis syndrome. It's not a formal diagnosis. There isn't a attenuated psychosis syndrome formally called out in the DSM, but you can diagnose other specified psychotic disorder, attenuated psychosis syndrome. So it falls under that broader category. And it is listed as one of the examples in the DSM-5-TR, which other specified psychotic disorders is an appropriate diagnosis to use. So, I mean, one thing that I know we work in a medical model, I understand that, which means we have to use diagnosis. So some people ask me like, well, we're getting referred people in this clinical high risk phase. They don't meet criteria for schizophrenia, so I can't call it schizophrenia. What do I call it? And then my recommendation is if they truly meet the criteria, then you call it other specified schizophrenia and other specified psychotic disorders. Attenuated psychosis syndrome is the diagnosis that you can use, which in most cases is found to be a billable diagnosis. I haven't found a program where it's not yet, but I haven't also visited every program in the country either. So anyways, if I sometimes use these terms interchangeably, unintentionally, you may hear other professionals use these terms interchangeably, but they all mean, they all mean similar things, same things. What is recommended is that we use valid and reliable tools to identify these individuals. So there was a time as DSM-5 was being developed, when we were shifting between the criteria of DSM-4 to DSM-5, there was going to be a psychosis risk syndrome diagnosis, a formal diagnosis for this, not in the other specified category, but in a regular diagnosis of psychosis risk syndrome was being considered for DSM-5 prior to publication. Got to listen to the debates on whether or not this was going to occur. And I was under the belief, as many people were at the time, that this was going to be a diagnosis added to DSM-5, speaking to how long I've been around now. So I wrote a paper saying, okay, if this is going to be a diagnosis, then clinicians, particularly even at the graduate level, need to be trained on the tools to recognizing, because I was terrified that this was going to be overdiagnosed and we're going to be calling. So I was already recognizing overdiagnoses with conditions like schizoaffective disorder. Are we now going to have overdiagnosis of things like psychosis risk syndrome? We definitely don't want that. So I really wanted clinicians to be trained on it. Anyway, like 2 days after my paper was published, the DSM came out and said, hey, we're not going to do it. So useless paper. But regardless, I do now recommend that if people are going to use the other specified category, and we are going to diagnose people with this attenuated psychosis or clinical high risk for psychosis, we need to use valid and reliable tools to do it. The process which we believe works the best for this is that we start with screening tools. So these one-page sheets with anywhere between 9 to 25 questions, which a client can fill out. And if the score reaches a certain threshold, then that individual is assessed further for a full-blown attenuated psychosis syndrome. So start with the screening tools. Some of the ones I like are the PRIME screen, developed by Yale. Pretty short screen, kind of asks about, do you think that your mind's playing tricks on you? Things like that. Just a screening tool, not a diagnostic tool. It's something like it's akin to like the GAD-7 for anxiety or the PHQ-9 for depression. It's just tools that kind of help us recognize that there might be something there. So like the PRIME screen, the prodromal questionnaire brief, I like that a little bit better because it has a distress scale on it, meaning that it'll ask the question, do you sometimes believe that your mind's playing tricks on you, or do you hear things that you hear things that other people can't hear? And if the person says yes, then it asks how stressful it is for them. Because what we don't want to do is overdiagnose or over-recognize individuals who may be having cultural experiences or something that's really normal. So we are still looking for distress. So I like the PHQ, or sorry, not the PHQ, the Prodromal Questionnaire Brief, the PQB. I'll get my acronym screwed up sometimes. The PQB over things like the Prime Screen, or even the Early Psychosis Screener. But they're all good. I mean, they're all something that you can use in your programs to help identify these individuals. My recommendation is that your primary referents, have access to these tools. So you're sending them to your children's mental health system, your adolescent mental health systems. You're making sure school counselors have access to these. Whoever has access to adolescents has access to these screening tools. And if they score a certain amount over in one of these tools, they're then referred to you all as early psychosis programs to do the more advanced diagnostic work to determine whether or not this is truly a clinical high risk for psychosis and not something else. Then the ASSIST, the gold standard assessment tool, although a new one is currently being developed, is the SIPS. And the SIPS is a structured interview for psychosis risk syndromes. So you have to be trained to use it, but the training is available. There's also a tool that's been developed called the mini SIPS, which is a shortened version of the SIPS, and that training actually is available free online that will certify you in using the mini SIPS. For training on the full SIPS, there is you have to be trained by a certified Yale trainer. That can get a little bit tricky because there's only, I think there's like 8 or 9 of us in the world. So I'm one, and then there's a few others that have been certified to do that. So that training's a little harder to get, but the mini SIPS training, free online, go through it. I've been using the mini SIPS or supervising the mini SIPS being used at the hospital where I work. And I have found that to me, it seems like it's just as good as the SIPS. Now, we haven't fully studied that. We haven't done, concurrent validity trials or anything on the two instruments, but at least eyeballing it, at least from my experience, it seems to be just as good as the full SIPS. So I sometimes feel like I'm putting myself out of a job by not doing the full SIPS trainings, but I want you to have access to this. So the mini SIPS may be a better choice for you. Anyway, if you do identify somebody as having a clinical high risk for psychosis via a SIPS or mini SIPS, then this is where active treatment certainly is recommended. I'll get through a couple of these and then we'll take a break. So what we do know is that when we do look at people who've been diagnosed with schizophrenia, we can identify in about 90% of patients that they did have a psychosis risk stage. So majority of people that have schizophrenia did have a phase that was psychosis risk. So what we're saying is that people don't usually wake up having schizophrenia, that there is a progression of the condition. One of our challenges in this work is that the studies vary, but it's anywhere between 13 to 35% of individuals who experience psychosis risk or prodromal symptoms will develop a psychotic disorder. So what that means is anywhere between 13 to 35% of people who score positively on your SIPS tool will go on to develop a psychotic disorder. That means maybe up to 2/3 will not. This is the big criticism of clinical high risk for psychosis work, is that people are being over identified. Now, my argument is, well, wait a minute. This group, even if they don't go on to develop a psychotic disorder, one, that may be because we're actually providing them treatment. And that's what some researchers think is why the range is so varied in some of the outcomes here, is that, well, now we've been doing this for a while. Maybe we're actually treating people and they're not going on to develop schizophrenia. We actually are preventing this if we're catching people early. Another argument that I make in favor of doing this work, even given that maybe 2/3 don't go on to develop schizophrenia, is that upwards of 85–90% of these individuals that score positively on a SIPS tool have a co-occurring mental health disorder. So meaning they have depression, anxiety, maybe PTSD, maybe a substance use disorder, maybe something else. So it's something you would be treating anyway. And the research is going to say, well, then go ahead and treat that disorder and then monitor the symptoms for CHRP. So again, these aren't individuals who, we're just picking up off the streets that are completely quote unquote normal. I hate using that term, but I didn't have a better one in my mind. We're not overly identifying kids that aren't already struggling. But I understand the criticism, like, are you mislabeling people and everything like that? I honestly believe that if we do this well, we're giving people really appropriate information, and we're treating any co-occurring disorders. And if we catch them and they go on to develop schizophrenia, then we've caught them really early. And if they don't, we've either prevented it, or at the very least, we've helped them with something else that they would have sought treatment for anyways. And we never told them they had schizophrenia, which some clients that do have clinical high risk symptoms get misdiagnosed as having schizophrenia. So I think of course, I'm biased, but that's my argument in favor of doing this work, in case you ever hear kind of the criticisms of this work, which you may hear. So the primary symptoms of this clinical risk group are they have at least one of the following in an attenuated, low kind of threshold of psychosis symptoms. So lower level delusions, lower level hallucinations, lower level disorganized speech, which without ever converting to full active phase psychosis. So just to give you some examples, an attenuated delusion might be the 15-year-old that starts to sit in back of the class because she's feeling uncomfortable because students are whispering about her. She believes that they are when they're not, laughing about her, about something, a thought that she's having that they couldn't possibly know, almost kind of like a pre-thought broadcasting symptom. And she knows it's silly, but it's captivating enough. And then it's beyond school bullying that she's going and sitting in back of the room and trying to avoid these individuals because she's worried they're basically are reading her mind. But could still say that's probably not true, but I feel better sitting in the back of the room. We call that kind of an attenuated delusion. These are symptoms that would fall in the clinical high risk phase, versus a full-fledged delusion where a 15-year-old absolutely believes people are talking about her, can read her mind, makes fun of her wherever she goes. She's know it's happening. And because it's happening, she's now isolating herself, and she's really uncomfortable in public because people are absolutely reading her mind. More active phase delusion. An attenuated hallucination, something that we might diagnose with a SIPS in a clinical high risk phase of psychosis, would be, maybe 2 to 3 times a week, a 22-year-old starts seeing colors on the wall, distorted textures, waves. They hear sounds. It lasts for a couple minutes. They maybe hear a voice. They're not sure, but if you ask them about whether it's real or not, or if it's a true sensory experience, they say, no, probably not. It bothers me, but I think it's my brain playing tricks on me. Insight intact, call it an attenuated hallucination, might be someone we monitor. Versus a full-fledged hallucination, the person believes that their voices are absolutely speaking to them. They refer to them in the third person. They'll criticize them. They'll say things like pat the cat. The individual believes that these voices are a true sensory experience. They're hearing them outside of themselves, and it's very frightening to them. Full-fledged hallucination. So we're trying to diagnose this attenuated psychosis, or this clinical high risk for psychosis, where we're really looking for people who have these attenuated versions of psychotic symptoms, but have never converted to full psychotic symptoms. All right. Let's go ahead and stop here. It is, 2:35 there? Sorry, I'm trying to do I'm in Oregon, so, okay.
Yes.
Okay, so let's come back at 2:50, and we'll take a 15-minute break, and we'll start up in about 15 minutes. Give yourself a biological technology, whatever you need to do. Talk to you soon.
Thank you.
All right. Welcome back, everybody. You enjoyed your break. I think we're going to go for we'll go for another hour or so, and then we'll stop and take questions. As I mentioned before, kind of in some ways trying to justify the clinical high risk for psychosis work and trying to identify individuals early. I think one of the criticisms of this was that we were going to overdiagnose people by doing this early recognition, and that could cause difficulties. Well, I like to cite this particular study that looked at a sample of well-trained mental health clinicians, including psychiatrists, clinical psychologists, and general practitioners. And what they found, and just kind of looking at identifying individuals who had attenuated psychosis or clinical high risk for psychosis. And some of the key findings in this was that the APS, or the attenuated psychosis syndrome, was commonly mistaken for a full threshold psychotic disorder. And that it certainly was considered a clinically significant, well, let's start with the first finding, that attenuated psychosis was mistaken for a full threshold psychotic disorder. So what really was happening is that individuals are taking what is an at-risk disorder and calling it a full disorder, and then engaging in treatment. If you look at the third bullet there, one of the other findings was that most often recommended treatment was antipsychotic medication, which even the American Psychiatric Association has come out and said that when individuals have attenuated psychosis or clinical high risk for psychosis, that there's a general recommendation to not provide antipsychotic medications, as because a certain percentage do not convert, we might be doing more harm than good with this. So there's a danger in not being trained in this. And that's maybe that when people actually have these attenuated symptoms, they actually are being diagnosed with full threshold psychotic disorders when in fact they don't actually have them. So I think in our programs where we're trained to really be looking at clinical high risk, we're not diagnosing them with a full threshold psychotic disorders. We are keeping them at this clinical high risk. That means we're using different language, different treatments, different approaches, probably in most cases much more appropriate. But overall, the finding still was that this attenuated psychosis syndrome is a clinically significant condition, meaning it's not a benign condition, that there is still significant levels of distress, and there's probably, which we do know, there's also co-occurring disorders that also require treatment. So in short, by doing clinical high risk of psychosis work, one, we are catching individuals who potentially are at risk of developing psychosis, but we're not overdiagnosing them, yet they still have clinically significant symptoms that do require treatment. So again, that's more my argument for why I think this type of work actually is a good thing when you're well trained at identifying individuals in this phase. I'm going to go through some of the screening tools. Sorry, that is difficult to read, but I can send you the actual tools. And there's actually a link on my one of my PowerPoints to one of these tools. So this is the tool that I like for screening, the Prodromal Questionnaire Brief, or the PQB. I think this is, again, I like it because it does have the distress scale. So the client does answer yes to one of the symptoms, that then it does follow up with how much they're distressed by it. And if they do endorse the symptom yet aren't distressed by it, it doesn't count in the total. Again, because we don't want to be trying to over-identify symptoms that they're not distressed by. It is a longer tool. It's up to 25 questions in the most recent version, which I did get some pushback from agencies when I asked them, hey, could you give all your new adolescent clients this tool so we can make sure we can pick up on anybody who might be at risk of developing psychosis? They liked the concept, but didn't like the length. Felt that it was too long. Fair enough. It is a longer tool. So I then went and highlighted 5 questions. So that's where the highlights are, that tend to have the most predictive validity towards conversion to psychosis. So like the most at risk of the questions. So I said, if you're going to use this, if you can't use it all, at least ask these 5 questions. So just to kind of help out agencies who I do recognize that clients can become overwhelmed with paperwork and screening tools, and they're asked to fill out lots of different data points. I understand that. And I also want to capture individuals who might be at risk of developing schizophrenia so we can prevent serious consequences. So trying to balance those things. And I have this tool highlighted. If you want me to email it to you, you can just send me an email and request it, and I'll send it to you. So when to refer to the SIPs. So it's, again, not everybody who should go through the SIPs tool. Not everybody needs this level of assessment. And another level of feedback that I've heard from community partners is that the SIPs is a long assessment and they don't always have time, or again, it's not always needed. So, not something that we need to do with every individual. We do want to go through the screening process first, use one of the 3 screening tools that I recommended, whether it was the prime screen, the PQB, which is the one I just showed you, or the early psychosis screener 26. And then only refer for a SIPS assessment or even a mini SIPS assessment if they reach one of the thresholds on each of the corresponding screening tools. So if they scored a 6 on the prime on any item or 5 on any 3 items, then you would refer to the SIPs. For the PQB, any distress score of 5 to 7 or more, refer to the SIPs. For the EPS 26, and all of these are available open source, so you can Google them and download them and everything. And the scoring instructions are listed. For the EPS, any score of 33.5 or higher, refer for the SIPs. That link here is an online version of the SIPs. Or sorry, not SIPs, sorry, an online version of the PQB. That is hosted by Portland State University. And what it does is it basically took all the questions on the SIPs. And then if they reach a threshold of that score between 5 and 7 or higher, it'll send them a message at the end that says, you have a score that's indicative of someone who might be helpful to talk to a professional further. If you would like to do that, here's links to do that. We actually took out some of the language in the PQB that talked about you might be at risk of psychosis, and so we didn't want to scare people. Got some feedback from some focus groups, said, hey, maybe take that word out and just say that it might be helpful to talk to a mental health professional further based on your score. So that's what this particular online tool will do. So you can have clients fill that out. It's tied to Oregon, so if they're in Oregon, it can be sent directly to a provider in Oregon. If they're nationally, it will just say that you might want to talk to somebody locally to get help. So we did create an online version of the PQB for you. Okay, and once the individual then moves to the SIPs, the SIPs is again a much more advanced tool. It is a clinician rated interview. So the client doesn't rate it themselves. Clinicians rate it based on responses from the client. There are 4 symptom domains that we assess: positive symptoms, negative symptoms, disorganized symptoms, or general symptoms. And then each one of those is a Likert scale going from 0 to 6, which 0 is absent. 3 or 4 is kind of in your moderate range. Anything. And then 5 is severe, but not fully psychotic. And 6 is that the person actually is already psychotic and would not be eligible for a clinical high risks program, but may need to be seen in a first episode program. The scores that we look for that we would bring in are individuals who would score a 3, 4, or 5 on the positive symptom scales. So really focusing on the positive symptoms, it has to score a 3, 4, or 5 to be considered clinical high risk for psychosis. 6, again, already psychotic. Once you're psychotic, you can't be pre-psychotic. So once you've crossed over, even if you're in a residual phase of schizophrenia and your insight is back, you've already passed that threshold. So you've already been psychotic. You're no longer at risk for psychosis. And a 0, 1, or 2 just means it's mild or not there and not anything we're going to worry about. The tool will help create one of 3 diagnoses if they meet criteria: the brief intermittent psychosis syndrome or psychotic syndrome, attenuated psychosis syndrome, or genetic risk deterioration syndrome. The most common diagnosis is attenuated psychosis syndrome. Roughly about 90% of individuals who score positively on the SIPs are going to score in with that diagnosis. Some will score what's called this brief intermittent psychotic syndrome, which means that the individual actually does reach a threshold of psychosis. So it scores a 6 in some of the areas, but it's very brief, does not meet the time threshold that's required. And it happens pretty infrequently where the person just gets really psychotic, loses insight, but it's very brief. So that's another syndrome that we believe is an at-risk syndrome, but pretty rare. And then the other syndrome that can come out of the SIPS as a diagnosis is the genetic risk and deterioration syndrome. And what that is when the person has a first-degree relative with a psychotic disorder and they're having a specific deterioration on a measure that's embedded in the SIPS. If both those are present, we can diagnose genetic risk and deterioration syndrome, which is another, we believe to be another risk factor. But overwhelmingly, the most common diagnosis that comes out of the SIPS is attenuated psychosis syndrome or no diagnosis. That was a puppy. That was supposed to be my break, but I was a little bit behind, so that was my puppy break. What we do know is that, what I like to do, kind of show some positive images when I've given you a lot of information, just to bring down bring it back to your parasympathetic nervous system. And yeah, I'm going to shift gears into some more specific treatment recommendations now. So I just want to give an opportunity for individuals, if you have questions, to ask questions at this point.
So because the negative symptoms with schizophrenia, they mirror other diagnoses like depression and all that, is there any specific triggers that you notice that automatically directs you to use the PQB or the PRON?
Yeah, don't worry as much about the negative symptoms. That's not going to be a primary trigger for using one of the screening tools. Mm-hmm. Generally, it's a screening tool that I just say, if you're new to mental health care, you're between the ages of 12 and 25, just like you go into a clinic and you get a GAD-7 or a PHQ, around, depression or anxiety. Let's do this.
Administer. Okay.
All right. Administer it. Yeah. And let's see, because that's how we want to catch people, right? And they're, and if they are having negative symptoms, and maybe they're going in for depression because they think they're depressed, but it's really a negative symptom, and then they get this tool, and then they start endorsing a couple items. They're like, well, maybe these are early negative symptoms, and then we can at least start screening them more for a CHRP diagnosis.
Maybe I'll just start adding that when I do the PHQ 9.
Yeah.
I'll just add the PQB.
Yep.
Okay.
Yep.
Thank you.
Yep. Okay.
Dr. Melton, Sally in the chat has asked if you could please repeat the SIP criteria. She missed something about 3, 4, or 5, but not 6.
Okay, good. Yeah, so I went over that really quickly. So obviously we'd go in much more detail if you went through a full SIPS training, but it's a 0 to 6 scale on what we call a scale of positive symptoms. And that's going to be our primary diagnostic features. So we'll rate that 0, obviously no symptoms, 1 or 2 mild, but not threshold symptoms. We don't worry about 0, 1, or 2. 6 would mean that they're already psychotic. So if we went through the tool and we found that they were already psychotic, then they don't meet criteria for clinical high risk for psychosis because, well, they're already psychotic. But 3, 4, or 5 is your at-risk threshold.
Thank you. Sally says thank you as well.
Okay.
Linda has asked in regard to FEP, how do we, it says TEAT, I'm guessing it means treat, but Linda, if you mean test, please feel free to correct me. How do we treat major depression, she said, with psychosis, PTSD, and bipolar 1 with psychosis? Are they admitted into an FEP program?
In some cases, individuals with bipolar with psychosis or major depression with psychosis are admitted into first episode or early psychosis programs. Some will not, because those aren't technically psychotic disorders. Those are mood disorders and need to be treated. Their treatment recommendations are that they're treated as mood disorders. So if somebody has major depressive disorder with psychosis, primarily we want to treat that as a mood disorder, because if we treat the mood, then what's supposed to happen, doesn't always, but what's supposed to happen is that then the psychotic symptoms tend to reduce and or go away. Bipolar disorder, same thing. Most of that's going to happen during a manic episode. During a manic episode, the person, the most common symptom in bipolar disorder with psychosis is grandiose delusions. And so when you treat the mania, although some of the medicines are the same, you might be using Abilify or Zyprexa for both of these things, but once those symptoms are treated, the psychotic symptoms tend to go away also. PTSD, we'll talk a lot about this in the differential diagnosis. There is not a PTSD with psychotic features category in the DSM. So when you're working with PTSD, there's a few things that could be happening. One, they have PTSD, and as part of the PTSD, they have what's called psychotic-like experiences, which aren't fully psychotic, but also not attenuated. And then that's more of a trauma disorder then at that point. Or the individual has both PTSD and a psychotic disorder, and so they're differentiated in that way, but then treated individually. And I really like the diagnostic workup with those, because we oftentimes, again, once somebody reaches like a psychotic threshold or they meet criteria for psychotic disorder and they have anything else, it's almost like we forget about the other thing. It's like they have a psychotic disorder, we have to treat that, we have to treat that. I mean, if they have a trauma disorder, we also know that those disorders are going to cause significant levels of distress. Distress increases psychotic symptoms. So treating the trauma also helps the psychotic disorder. But first, we have to differentiate whether or not it is truly PTSD and a psychotic disorder, or PTSD with psychotic-like experiences. Different treatments for each of those. Again, I'll talk about that when we get to. That's my, again, teaser trailer for my differential diagnosis talk later, where we'll go into that in much more detail.
Thank you, Dr. Melton. Linda says thank you. Casey asked about sharing slides. Casey, Dr. Melton has generously offered to share the PDF of his presentations with us. So he'll send those to me. And then when I send out the YouTube link with the recording, I'll also include those PDFs.
Yep.
Thank
you bet.
All right. We've got no other questions in the chat.
Okay. Thank you.
Question. Sorry. This is
no.
I was going to type it, but something's going on with my screen and I can't see the words correctly.
No worries.
Would you talk about IQ in regards to FEP? Because I have a client that has an IQ of 65 and other developmental disabilities, but he's also experiencing first episode of psychosis.
Yeah. So again, they're not mutually exclusive, right? So someone can have a lower IQ or be in an ID system, intellectual disability system, or developmental disability system, different terms used kind of across the country, and have psychosis. That's completely possible. The big question with that is, are those individuals most appropriately served in an early psychosis program? I think that's the big question. And the answer to that is really depends on how your early psychosis program is set up. Many of them across the country are set up as temporary, meaning that we'll serve the individual between 2 to 4 years. And then we'll refer them, out with the ideas that we're catching people young, that maybe we're curbing the consequences of the disorder, and they don't need as intensive treatment after we've provided intensive treatment for a while. Or if we catch them in a CHRP phase, we've maybe prevented the psychosis altogether, and they may not need as much ongoing treatment at all. Individuals with IQs of below 70, we generally understand are going to have long-term needs. So the question is, do we treat them intensely for 2 years only to refer them back to an system where they're going to have ongoing care needs met, housing, work, those type of things. My general advice in this, and what Oregon is trying to do, we're actually piloting this right now of individuals. Historically, Oregon has not accepted individuals with IQ below 70 into their early psychosis programs. Again, not because they couldn't develop schizophrenia, but because we had early experiences when we were developing the program, when we were accepting those individuals, that when we then 2 years later, when we tried to refer them back to the ID system told us no, because then they were too old, or that their symptoms could be better explained by their schizophrenia, even though we were saying, no, they had a low IQ when they started. And they're like, well, you should have referred them then. So it was just this terrible dynamic that was set up. So we then switched it and said, well, first thing we're going to do is make sure they're eligible for the ID system. Then we're going to refer them to that system. Then we'll act as consultants, to the ID system, but we're not going to be the primary treatment providers because we don't want to, because we are temporary. At least that's how we were set up in Oregon. Now Oregon is trying a partnership with the ID system where we're working alongside each other, making sure they're first eligible for the ID system. That has to be in place first. So that eligibility is there. And then we're serving, doing some of that adjunct early psychosis work, knowing that the ID system is going to be partnering with us the whole way. So is that kind of get at what your question was? And that's a good one.
Yes, that's
Okay.
exactly what I needed to know.
Okay, all right. Yeah, you bet. You bet. Okay. Great. All right. Well, I'll go jump back in, finish up the presentation. One of the primary treatment models for treating both clinical high risk for psychosis and first episode of psychosis is the coordinated specialty care model. This is the general term used for the model that is most commonly used in early psychosis programs. And it's a wraparound model in which, we use kind of like an ACT, a sort of community treatment model in which the individual has wraparound services using different disciplines and different techniques. So there is no unified agreement on all the elements that should be in coordinated specialty care. So I tried to be as inclusive as possible as I described, at least this model. Some coordinated specialty care doesn't have, say, occupational therapy or a specific substance use treatment provider or something like that. So just recognize it's really the point of it is the individual has a team of individuals that they work with. And usually those involve some kind of counseling, both individual and family therapies, supported employment education, peer support, occupational therapy in some cases, a specific substance use treatment provider in some cases, psychiatric care, essentially medicines and case management tend to be the common treatment in coordinated specialty care. There's different therapy models that get used. Some people like the Navigate programs, like the IRT, the individual resilience treatment. I'm trained in cognitive behavioral therapy for psychosis, so I have a bias towards that, but both models are good. I do agree, though, within coordinated specialty care, probably good to have some type of structured therapy model, whether it's IRT, CBT, and in the at-risk psychosis, you probably want to have people trained in models that are that treat other disorders like trauma. So maybe DBT provider or EMDR provider, other forms of structured therapies for disorders that are not targeting for the at-risk psychosis. Family psychoeducation, substance use, peer support, OT, and then prescribers, all should be part of this CHRP coordinated specialty care team. One thing that really should be present in when you're working with individuals with clinical high risk for psychosis is ongoing monitoring. And then ongoing monitoring and a frequency of contact. We recommend that they have a contact with a team member at least every 2 weeks. Obviously, if they're doing therapy, it should be weekly, but at least every 2 weeks. And then with reduction in treatment guided by clinical measures, specifically maybe the SIPs. There is a scale within the SIPs that you end up redoing roughly about every 90 days to determine whether or not their symptoms are progressing towards schizophrenia, staying the same, or improving. So the treatment frequency really should be guided by outcomes on clinical measures, particularly for the CHRP group, because you're really trying to determine whether or not they're going to move towards schizophrenia or not. So what do some of these treatments look like with cognitive behavioral therapy for psychosis? You can use techniques that really involve insight-oriented strategies, where you can do reality testing or behavioral experiments. So if somebody has insight into their even attenuated delusions, you can do reality checking. I've had clients ask people that they trust whether or not that individual really is reading their mind. They're going to be able to do that. When a person has insight, you can do that type of work. But you also should be doing, again, what I've kind of said earlier about trauma. Same thing is true with kind of your CBT, if you have somebody who has a co-occurring trauma disorder, that should be treated also. We just cannot forget about the other disorders. So whether that's anxiety, depression, trauma, we need to be using some form of standard treatment to make sure we're targeting those disorders as well. There's some evidence that if we treat those disorders, we might actually reduce the CHRP symptoms as well. Case management should be focused on stress reduction, not necessarily disability resources. I mean, I recognize that case management as an intervention is often used to help people gain access to eligibility entitlements, particularly around the areas of housing, resources for food insecurity, disability, those type of things. Whereas this phase, we don't want clients to really be thinking about disability or disability-based systems. We're hoping that our treatment will be effective enough that they don't move towards a severe mental illness and they won't need full disability systems. So we really kind of recommend more strengths-based case management that focuses on informal resources versus your more formalized resources. So informal resources would be resources that any one of us would be eligible for. If they enjoy, I don't know, playing basketball, helping them get a membership at the local YMCA or something like that, something that we all would be eligible for, but they might have a barrier to. That would be more of the emphasis for case management in the clinical high risk phase. If you're working with families, and I use the term family very broadly, also referring to anybody who the individual feels is supportive in their lives. If you're working with individuals or with families and their support systems, we really need to provide some education around what CHRP is and what it's not, so that it's not schizophrenia. That even though they're talking about maybe hearing a voice, it's not at a level that we call schizophrenia, and then that could be explained by any number of things. So the family or the support system doesn't panic and think that their son, daughter is developing schizophrenia, because they may not be. We do have learned there's been some concern again in the CHRP world that even talking about CHRP can be stigmatizing. Generally, the research has found that not to be true, other than within some cultural minorities, that the words psychosis, pre-psychosis can be found more stigmatizing. In general, people, though, however, feel that the symptoms themselves are what's stigmatizing, not the word. And what's most stigmatizing with individuals is the perception of perceptions, meaning they're not worried so much about what's going to happen to them based on their experiences. They're worried about what others think about them, which would make sense. They're adolescents, right? Adolescents oftentimes worry about what others think. So it makes sense that individuals who are in CHRP programs and are told they're at risk for something may be worried about how others perceive them versus their own internalized stigma. Substance use reduction or prevention is essential with clinical high risk for psychosis, particularly with marijuana. Marijuana is the #1 substance that leads to conversion in this group. So this is the substance that, if used consistently, is a high risk factor for conversion from going from at risk to first episode, even with treatment. So we have found that marijuana use is our best predictor of the worst outcomes within this group. So we need to be working on reducing that use if they are using, or preventing the use overall. Don't overly focus on the term around self-medication. Although we do know that some people with trauma-related disorders do self-medicate in terms of using substances to treat their trauma-related symptoms, I have found no evidence that occurs in the clinical high risk, or even really with schizophrenia, that self-medication is not something that happens. Oftentimes, this group uses substances for a fairly normal and expected reason, which is for enhancement of self, to have fun, to engage with others, is the #1 reason why they're using substances, and it's not for self-medication. So yeah, studies after studies have found that is not the reason why this particular group is using, which I think that's important because when I try to help people reduce their substances, I want to understand why they're using, and it's oftentimes because their friends are using, their families are using. It's kind of a culture of use, and to give that up really is a grief process. That they may not connect in the same way they've been connecting with their family and friends because they shouldn't be smoking marijuana anymore because of the potential risk that it has on their brains in particular that their family or friends don't have. I sometimes use the analogy of an allergy. It's almost like allergic to this marijuana, which is really, really unfortunate because I know your friends are using, I know your family is using. In Oregon, marijuana is all over the place. So families, I mean, I've asked clients, hey, where are you getting it? And they're like, oh, my parents give it to us. We all smoke it together. It's kind of a culture. So yeah, so that's a grieving process. That's a loss if they have to stop or cut down. So yeah, that's kind of always kind of integrated into my treatment around substance use. Supported employment and education models can be helpful for this group. I do not think that the fidelity-based individual placement and support model is the best choice for supported employment for this group, just because the research around that particular model has been studied on individuals with more chronic schizophrenia who have much different needs than a 17-year-old who might be developing schizophrenia. So I wrote a paper that really talks about how we take some of the elements of this IPS supported employment model, which has a lot of good features. It's just different population that it's good for. And then we make some developmental modifications to the model. And that was my last talk yesterday. If you want to watch that, I kind of go over those recommendations. What you do need to understand in terms of supported employment and education for this particular population is understanding educational needs, because a good portion of this group is in high school. So understanding IEP rules, 504 rules, IDEA rules, and being a lot of ways an advocate for accommodations to keep them in school is helpful. We have learned that in our programs in Oregon that if we catch people in the CHRP phase or even first episode phase, frankly, and they're in school, they stay in school and they graduate at a higher rate than the average student in Oregon. So you're more likely to graduate in Oregon if you develop a psychotic disorder in high school than a student overall. And that's just because we provide so much support. Honestly, if we helped everybody with this much support, we probably have a much higher graduation rate overall. And then maybe offering things like non-formal educational groups, like we used to do, like homework groups. It's a space for people to do homework, making sure people get tutoring, those kind of things, really helping them get through high school. Peer support is tricky at this age. There's a wide range of peer support models out there, and there's still arguments on what's the best peer support model for this particular phase. The general consensus is your standard self-disclosure model may not be a good fit because this group is at risk. They're not fully psychotic. So we like more kind of mentorship models in this case. Also, a lot of peer support models are really meet the client exactly where they're at. And that's fine with adults, but when you're working with adolescents fall under certain laws that adults don't have. So you can't always meet a client exactly where they're at when they're adolescents, just because they're still adolescents. They're still considered minors, and minors unfortunately fall under different laws than adults do. So we like the idea of mentorship, peer mentorship with this group, which focuses on non-diagnostic related experiences, life experiences, finding two people that really enjoy similar things. We have a youth hub in the hospital where people can come and play video games and do things like that. We do like occupational therapists can be incredibly helpful with this particular population because they are trained in certain measures that pick up on the subtle non-overt signs of clinical high risk for psychosis, including the cognitive deficits that I talked about earlier and some of the sensory challenges. So through those assessments, then we can make specific recommendations for accommodations at work or in school. And it's been incredibly helpful. I mean, we've had strategies as simple as a client is currently in the middle of the room. They tend to be over to middle of the classroom, too much sensory input, move them by the window, allow them to gaze out at the window without kind of calling them out on it, almost kind of giving them cognitive breaks and sensory breaks. And then their grades improve just by moving their desk. And that was determined from an assessment done by one of our OTs. If you don't have an OT, getting some training in some of these basic cognitive and sensory models, getting training in the adult adolescent sensory profile, I think is one of my recommendations. Using some basic cognitive measures, the CASI, things like that. It can just get us some basic cognitive measures are going to be helpful. When it comes to medications in this group, the general consensus is that you avoid antipsychotic medications just because the risk that the antipsychotic medications can have is greater than the benefit in this particular group. Unless they're at a 5 on the SIPs and they're deteriorating rapidly, then that's when antipsychotic medications are recommended. Certainly other medications can be used if someone has significant depression. Antidepressants are fine if the prescriber agrees with that and it's not having harmful effects. This is a group that tends to be at higher risk of metabolic issues, kind of pre-diabetic issues, even without medications. And we don't know exactly why that is. And the medications just make metabolic disorder worse, but this is also a group that's has a higher risk of metabolic concerns. So that should just be monitored on a regular basis and maybe supporting them with exercise and diets, and because they're at a higher metabolic disorder risk, this group is. And then in terms of monitoring, you should be doing a tool called the SOPS, which is part of the SIPs. You do that every 90 days. Maybe more frequently if the person has a 5 on the SOPS, you might want to monitor them a little more frequently because conversion is at a higher risk. And there are certain measures on the SIPs that tend to predict conversion to psychosis at a higher rate than others. So this may not mean anything to you if you don't have SIPs training, but sections P1 and P2 on the SOP scale of the SIPs, if those are 3, 4, or 5, we want to monitor those symptoms closely. Those tend to be symptoms that are more likely to convert. And these are your kind of your attenuated persecutory delusions and your non-persecutory delusions. Some of your thought insertion, thought broadcasting, thought withdrawal symptoms. Those tend to be high converters in terms of the symptoms that go on to convert to schizophrenia. So we monitor those a little bit closer. If conversion does occur, if they do meet a 6 on the SOPs, if you are a time-based program, like you have 2 years and they've been in your CHRP program for a year and a half and then they convert to first episode, I would ask or encourage you not to punish them because our treatment didn't work and that they get another 2 years in your first episode program. This is advice I give to Oregon programs. Also do continue to monitor other symptoms. So if they are depressed, using ongoing PHQ-9s, if they have anxiety, GAD-7s, if they have trauma, PCLs, and making sure that we are targeting those symptoms as well, because non-treatment of those symptoms can also then lead to a conversion to schizophrenia. And none of this works really if we don't catch people early. Part of clinical high risk is catching people as early as possible. We do this through community education, through reaching out, talking to anybody who has run-ins with adolescents and say, hey, look for these symptoms. This was a poster that we designed in Oregon. It was done by adolescents. We got them together with a graphic artist, and they put together this poster. And then I went through these focus groups and said, hey, what are some symptoms that stand out to you that might be on the poster? So these are some symptoms from the SIP or from the prodromal questionnaire brief, the PQB, that this students told me would be helpful to be on the poster. So we have put a QR scan as well as a quick text to it. And this was feedback from the students who said, well, if you have this poster up and you have a QR scan, it might be embarrassing for the individual to be holding their phone up to it. So I have a quick text also. So we did that. And they said the most common place, or the best place to post these was inside bathroom stalls, because that's when you're kind of alone, private. And if you want to text or you have these symptoms, then this might be a good place to have these. So anyways, it's part of our community education campaign that we created, did these posters. isacommunity.org is the Oregon program, a lot of really great resources on that website. Okay. So that was kind of concludes my lecture on the clinical high risk of psychosis. Now, first episode, when the individual crosses over and on their active phase, and you can diagnose them with, say, something like schizophrenia. We're going to use similar treatments that we use with the clinical high risk phase. We're still going to use coordinated specialty care, still going to use cognitive behavioral therapy or other forms of structured therapy, supported employment, supported education, peer support. They just look a little bit different. So the treatments are the same overall, but how you use the treatment models slightly different depending on whether active phase psychosis versus clinical high risk for psychosis. So with CBTP, we're going to probably be using some of the strategies within that model that are helping people that don't have insight into their psychosis. So I brought it up earlier, but collaborative empiricism, which is really kind of asking about the experience that they're having without challenging the symptoms. You're not going to be doing necessarily reality testing. With people who don't necessarily have insight, I do some exercises called the alternative beliefs exercise, which basically is just like anything. There could be another explanation why this is happening. Not necessarily challenging it, but not everything we believe to be true is true. And maybe there's other reasons why that person was looking at you. It might have been because they're part of the government and they're tracking you, or it might have been they were just looking at you, And so there's, again, without challenging, just looking at alternative beliefs, and there's a stage-based treatment model that I use to kind of work them through kind of beliefs where they already have alternative beliefs. And then we work up to more challenging symptoms. I think one of the biggest errors that people make when engaging in CBT is that they jump right to treatments that are target sensitive symptoms. And when you do CBT, you really have to stage it. You really have to build up to what the individual can tolerate. So if someone has a belief that someone's putting microchips in their brain and tracking them, you don't want to start challenging that belief right away. You may challenge beliefs that they already have the ability to do alternative explanations for and understand why or how they got to that point. But I think we have that righting reflex, right? Where we just want to fix things, and so we go right to the most dramatic symptoms. We have to be more patient. We need to kind of build up to those before we challenge those symptoms. So again, different forms of CBT still want to treat co-occurring disorders, anxiety, depression, trauma with this as well. Case management takes more of an approach that is potentially focused on eligibility entitlements. If they've had a long DUP, duration of untreated psychosis, and they are in-house, they've been kicked out by the family, of course, we're going to be looking for housing resources. Food insecurity, we are going to be looking for resources to help that. We might be looking at disability, which I still, even with the FEP, we try to avoid that. But if the condition has gone on too long, disability may be a right choice for somebody. So case management, again, focuses more on formalized resources. Family education, it gets very specific about psychotic symptoms, but not at the same level, not trying to solve the big problems right away. One of the models that I really like is the multifamily psychoeducation model, which really focuses on solving problems step by step, week by week, not trying to solve schizophrenia, because once you try to solve schizophrenia, you're going to fail. But can you help somebody take their medicines more regularly or work on a conflict between the families? Some of these smaller challenges. That's what this model really does. Shared decision-making with family models are helpful. And not many early psychosis programs do this. I'm starting to see it more and more, which I think is a great model, which is family peer support. Having families supporting families. Almost like NAMI, but in NAMI oftentimes is families that are family members of more kind of chronic mental illness. but really kind of families who have been through these early stages and how that's different. And certainly substance use still needs to be addressed. Marijuana is still problematic. In the first episode, it does make symptoms worse, as opposed to essentially causing psychosis. Marijuana makes psychosis worse in this FEP. So we definitely do some more structured dual diagnosis strategies, harm reduction to try to reduce use. More traditional support employment models can be used with this group without some of the developmental considerations. If they're younger, then you certainly may need to be understanding IEPs and 504s and all that, those education models as well. Peer supports can be more traditional with this group. They could be more focused on shared experience of psychosis or having a peer that's also experienced psychosis. That tends to be more effective with this group. I still like OTs with first episode because they're still going to pick up on some of those sensory and cognitive issues that have probably been present for years. Once first episode hits, there's a general recommendation of use of antipsychotic medications. Most will use the go start low, go slow model. So the lowest possible dose that gets the best possible benefit. Ideally, because if people are going to stop medicines, they're usually going to stop medicines early. And they usually stop because of the side effects, not because of the benefits. And unfortunately, clients will experience side effects of antipsychotic medicines before they'll experience some of the benefit of them. So, checking in with people almost immediately after starting an antipsychotic medication. One study suggested that people are going to know if they're going to quit medicines within 3 days of use once they first start. So really even, generally early psychosis programs will say, I'll see you back in a week. And we think that's good. But we might need to be checking in on them in 2 or 3 days to see how things are going with the medicines. And certainly because side effects are prevalent, particularly metabolic disorder with even the atypical antipsychotics, making part of monitoring metabolic risks as part of your monitoring needs to be a real key feature of first episode programs. Generally, we've worried historically about the typical antipsychotics, your Haldols and your medicines that cause movement disorders. But we've actually found that clients are more likely to tolerate those than they are the metabolic disorders that the newer medicines cause. So the weight gain, some of the other health challenges that come with these newer medicines, clients perceive those to be worse than movement disorders. Clinicians perceive the movement disorders to be worse than the metabolic disorders, but they're not the ones taking the meds. So we do need to make this part of our treatment. Still need ongoing monitoring with this group. You're not using the SIPs or the SOP scales anymore. You might be using the positive and negative symptom scales to monitor psychotic symptoms, particularly negative symptoms. I think monitoring negative symptoms is important because that's one of the few symptoms that does not respond well to medications. So making sure that we're monitoring those and trying to find treatments for those. Quality of life scales, I think, are important. We do know that once somebody hits a first episode and they have delusions, sometimes the medicines help reduce those delusions, sometimes they don't. So having a scale that measures delusions may not be as helpful if the delusions aren't super treatable, but quality of life would be. So you can help people have good quality of life even with delusions. So our goals shouldn't always be around reducing symptoms, but also maybe also improving quality of life in spite of symptoms. And other symptom measures, if they do have anxiety or depression, certainly make sure we're targeting and measuring those outcomes as well. In general, the consideration for implementation of these programs is having common language approaches and understanding of treatment. That you kind of know the difference between CHRP and FEP, and that these groups are in some ways separated. Even if you have a treatment model that's covering both, so the hospital I work at, we cover both CHRP and FEP, but they're designated, so we know in our charts who's FEP and who's CHRP. So we know when we have to monitor, what we're monitoring, and what treatment approaches that we're using. I do recommend a standardized diagnostic process in which people can come into the program. So using a SIPS or mini SIPS for your CHRP group, using an instrument like the SCID, the Structured Clinical Interview for DSM-5 Disorders, for your FEP group, are helpful instruments. I'll talk more about those instruments. I already talked a lot about the SIPS. I'll talk more about the SCID in the differential diagnosis webinar. So we do have kind of specific treatment recommendations based on the phase of the condition that the person is in. And then making sure when we're talking to families and others that we are modifying our language, that we are using at-risk language versus more consistent mental illness language when we're talking to families. I am actually going to, we're going to get low on time here. So I think I have a couple minutes, sorry. Yeah, I think I can finish this. I'm just double checking. Also with first episode programs, it is important to be working with families or again, primary support systems. We know almost definitively that people do better when they have support systems. That shouldn't be surprising to you. But what we do know with schizophrenia, particularly first episode, that with when an episode occurs, so when a person crosses over from that active phase from that at-risk phase to the active phase, a family member is lost. What that means is a family member shuts down. And not to stereotype, but the research indicates that's usually the male parental figure, the person that may be identified as a dad, if there's a family system like that. That person is the first person to go away, whether that's through divorce or shutting down or something like that. Part of our work and why we need to focus on families is we need to keep families and support systems intact. So we do that by explaining symptoms to family, having them in part of family groups, helping them learn problem-solving strategies for managing and supporting medications. Although a dated term, but expressed emotion is still a thing. That high levels of expressed emotion within family systems do predict relapse. So helping reduce family conflict, over-involvement, reducing enmeshment, all of those things have been shown definitively to increase psychotic relapses. So helping families reduce those means we potentially can help prevent relapses. Doing safety plans with families, doing crisis plans with families. So we're doing helping families understand what the early warning signs of relapse are, what the triggers to relapse are, and then what to do when early warning signs are present, when triggers are present, those type of things. So having very detailed plans so the family can manage if you're not around. We know that a first episode of psychosis has a significant risk on the family system, causes high levels of distress, depression, and anxiety amongst family members. So not only should you be providing kind of education and support to the family, it's not unusual that you might recommend that families go get their own treatment. This really is a grief process. I've talked to many families who've given me a kind of a similar theme, that once a client has reached the first episode, they're grieving now. They're grieving the loss of what they believe that their children are going to be. Now, not that their children can't be that, but we know what the messages are around schizophrenia in our culture. They're pretty negative, and families pick up on that. So they hear the term schizophrenia, they're starting to grieve a loss. I've had multiple families tell me that this diagnosis was worse than death, because death was definitive. Schizophrenia is, they're like, we're always walking on eggshells. When's the next relapse going to happen? They're doing great now, but what about tomorrow? So we really need to work hard to make these early intervention programs should be systemic programs, meaning that we are working within family systems. We need families. And again, I use the term family as a broad term. This could be friends, other support system. I like to ask clients, can you name 5 people in your life that you could call 24 hours a day, 7 days a week? And whoever they can name that would fall on that list, whether there's 5 or not, that's their primary support system. And those are the people that we want to work with. Yeah. Okay. So the question is no longer should we be doing early intervention work, but it's how we do it. And that's what we're working on now is like, okay, do we do CHRP work? If we do CHRP work, what measures are we using? What messages are we setting? What's our treatment approaches? If we're doing FEP work, how long are we treating them? How long of the DUP are we going to accept? What treatments are we using? So it's more about, we know early intervention works. We've got enough data. We've been doing this for 20, almost 30 years now. And so we know that as an intervention is effective. What we're really just trying to figure out is how we do it. What are those key elements? What is something that our team can put together? What does our early intervention team look like? Who do we treat? How do we do it? And that's my younger daughter and her sheep. She likes to know that I put her in presentations so you can see her. Also, so it kind of replaces the cute image. That is going to end our presentation. There is all of my references. And here's my email and phone number again, if should you want to reach out to me with any follow-up questions or requests. And I'm happy to take any questions or cases or whatever is going to be most useful right now for you all. Thank you very much.
I'm interested in what tools you've used when dealing with PTSD and psychosis. I had a youth a few years ago that we were trying to figure it out. And so I did both the SIPs and also just the CATS assessment. And it took some time working with her. I finally figured out the hallucinations were really flashbacks to dad and the abuse.
Yeah, right.
I just didn't know if there were any shortcuts because it took me several months to really get a handle on what was going on.
I like the skid for this. The structured clinical interview for the DSM disorder is the SKID clinical version. It's a little bit shorter than the full SKID, and it does a nice job of really pulling the characteristic of psychotic symptoms, and of really kind of measuring what's a typical psychotic symptom and what exactly it has to look like. And then it goes on to trauma, as like substance abuse and some other things too. And you really start going through those symptoms very systematically. And then you'll start, even if you picked up on some of the trauma symptoms as psychotic symptoms early, you'll then transition to the trauma section and you'll start to realize, oh, wait a minute, those symptoms that the client was reporting as psychotic symptoms are not psychotic symptoms. They are trauma symptoms. So it almost it condenses exactly what you did, by using kind of the CATs and the SIPs, but it just kind of puts it all in one instrument. Hopefully that was helpful.
It is. Out of curiosity, is that one free or is that one cost money?
It does cost money, but it's not overly expensive. I think you can get the SKID for roughly between $50 to $70. Something. So make your agency buy it. They should have these tools. I mean, First Episode program. I mean, everybody should have these diagnostic tools. I think diagnosis, we don't do a great job with it overall. And I think we could all do a better job with it.
I'm an executive director for a foster care agency. So we're not First Episode Psychosis, but we work outpatient and it's amazing. I'm training all my clinicians in SIPs because it's free training, and how many kids we're identifying in the community is just almost flooring how much we're seeing. And the closest program is Lexington. So some of our families don't have the money to drive to Lexington. Sure. So we either provide the treatment or they get nothing.
Okay. Well, thank you for doing it. Thank you for getting an understanding of early psychosis, what it is, what it isn't, and then differentiating it from trauma. That's going to be important for your group for sure.
I have a question, if you can hear me.
I can't hear you, yeah.
Okay, I'm just curious if you're hearing some myths or assumptions in your area related to some of these community targeted acts of violence. I feel like that some of these mass shootings or some of these things, people want to find a quick and easy answer. And so sometimes they refer to this as a mental health crisis. And while that certainly could be the case for some,
sure,
I feel like that as mental health practitioners, we want to work to dispel those myths and assumptions. And I'm just curious if you have some advice on how to best do that.
Yeah, it's complicated, right? Yeah, no, certainly not as out there. I mean, I think mentioned earlier, what do our brains like to do? We like to consolidate. We look for easy answers. So if there's this violent event, of course, we're going to go to the easiest explanation, which is, well, they must have had a mental health problem, but it's certainly much more complicated than that. I've actually done a review of a lot of particularly the school shootings, because mental health gets blamed, specifically schizophrenia gets blamed for this. And really none of those individuals had schizophrenia. Most again, may have had other mental health conditions, but not even related to the shooting. And I think we need to do a better job. And the DSM does this for us, but we're just not well trained on it. Where the DSM explicitly states that, acts against that are kind of antisocial in nature are not necessarily mental health conditions, which is why they really caution against using diagnosis and kind of forensic explanations for crimes. Most of our crimes related to mental health that have schizophrenia are confusion. Like I've had a client that broke into somebody's house thinking they lived there. Those type of things. So of course they were charged with a crime. It was due to their illness. But most of the shootings, these are, disturbed individuals in some ways, of course, but not necessarily mental illness. That's hard to wrap our mind around. Like, what caused this? What caused this? What caused this? Can we acknowledge that it's a really probably complicated system of multiple factors that quote unquote caused this, that may not be as simple as schizophrenia. And oftentimes people with schizophrenia avoid people. They go away from people. If you look at Barbara Kornblatt's model, that line with the psychosis and the Cassis model, social isolation is a big part of developing schizophrenia. This is a group that goes away from people, and really less likely to be violent. On the one big study that showed, this is an old study, it was in the old schizophrenia handbooks that they used in medical school, and it talked about there was a 10% increase in violence amongst people with schizophrenia. So that was a common cited study around violence and schizophrenia. And then when they redid that study, or actually looked at the patients that were a part of that study in a little bit more detail, they found a couple things. One, they found what was most predictive of violence in that study was people who had co-occurring substance use. So the people with schizophrenia alone were actually less violent than the people that had less violent in the normal population or population not diagnosed with schizophrenia. And then when they looked at this substance use group, it's okay, well, it looks like substance use and schizophrenia, that's the mixture. That's what violence is. When they compared that number to violence rates amongst people with substance use alone, the people with substance use alone had a higher rate of violence than people with schizophrenia and substance use. So it's almost like schizophrenia is a protective factor against violence. So if you have schizophrenia and you use drugs, you're still less violent than somebody just using drugs. So there's things like that are out. These are all these myths, but it is out there. I was on a radio show many years ago after Sandy Hook, and we got a bunch of money. What do we see happens after these mass shootings? Our lawmakers fight like there's nobody's business on whether it's guns or not guns and all that. And then they kind of ultimately decide on, well, we can at least throw money at mental illness. That's an answer, right? And so, yeah, we got a bunch of money following Sandy Hook for some of our programs. And they asked me, well, do you think this funding is going to support the reduction in school shootings and violence? And I said, no. I have no evidence to support that statement. I appreciate the mental health stuff. I think we're going to prevent a lot of other things. I think we're going to help people graduate from high school. I think we're going to help, people stay off of disability. I think we're going to keep families intact. And maybe those things can help violence in other ways, but those are all not necessarily causal factors. Those are potentially mitigating factors. So yeah, it is complicated, but it's not our group. Our group is not the ones doing these type of violent acts. We really could only find of the major, at least the well-publicized shootings, the one individual who I believe was psychotic was and I'm forgetting his name now, that shot the Arizona shooting of the I think it was the senator that was shot. That person seemed to be psychotic. So it's not that it can't happen. Certainly, people that are psychotic can also be dangerous. But but it's definitely the exception, not the rule in that case. Like I had one client that I honestly liked him so much better when he was psychotic, because when he was not psychotic, when he was on his medicine and doing well, man, he was a jerk. You know, but when he was psychotic, he was kind of a nice guy. but it gotten other, obviously, he was causing other problems. So they're not mutually exclusive, but almost psychosis in some ways, it really is a protective factor for violence. Hopefully that was somewhat helpful. It's complicated though, definitely, and that's just it. I mean, one of my mentors said, "There's a simple answer for every complex problem, and that simple answer is wrong."
Interesting. Thank you.
Yeah. Right. If there's no other questions, it was my pleasure to sit with you for the last few hours. Hopefully this was helpful. Again, give me feedback, and you can also reach out to me if you have follow-up questions, and we'll hopefully see some of you in the differential diagnosis lecture.
Thank you so much, Dr. Melton. And before you all log off, I'm just going to provide a little bit of additional info. In the chat here, I'm going to include again our schedule for this FEP series. As I said, this is the third session of 8. In the chat as well are linked the Eventbrite link to register for any additional sessions, as well as a post survey. If you all are willing to fill out that survey, we would really appreciate it. That is also how you can request a certificate of attendance. This live training is eligible for social work CEUs and may be eligible for additional CEUs. We will be sending out the YouTube link with this recording within the next week. And if you have any questions, please feel free to email our Executive Director, Marcy Timmerman. Her email is in the chat as well. Thank you so much, Dr. Melton. Thank you, everyone, for joining us, and we'll see you next time.
Bye-bye.